Good morning. I want to welcome you all to the Medical Board of California, and I want to ask that you please turn off your cell phones, or at least turn them to silent, and if you would turn off your Blackberries, because they do affect the feedback. Also, I realize that this room acoustically is not the best. In other words, it's not good. So if anyone is having a problem hearing in the back, if they would either let Ms. Thompson or one of the staff know or let me know, I'll try and keep a handle on it. But board members, I would ask everyone to use the microphone appropriately, speak into the microphone, because it makes it a bit hard. You also will probably notice board members using laptops during the meeting. They are using the laptop solely to access board meeting materials, which are in electronic format. I'd like to remind all speakers to complete a presenter slip. It looks like this. It's in the back. And hand them to Ms. Thompson. Ms. Thompson, if you would raise your hand so we would know that's the person who needs to receive it. I would remind all people that would like to speak, it is your opportunity to have 3 minutes. It is not a conversation. You will not be receiving responses or answers from anyone sitting at the table. Any issues that are under scrutiny of whatever's going on shouldn't be addressed. So it basically is your opportunity to let us know about any issues you might be interested in letting us know about. And again, the 3-minute constraint. We had a committee meeting that went quite a bit longer than expected this morning, so my apologies in advance. And to know that we are going to we're going to take a few things out of order now, and we are going to move forward on the agenda, but after this, there will be the enforcement committee, and they will meet for their appropriate time, and then we will reconvene to continue with the board meeting. So I'm going to ask your indulgence and my prerogative to move to item number 17. Item number 17 on your agenda is the... Oh, apologize. First, I need to call roll. So, Ms. Thompson, would you come forward, please, and call the roll?
Dr. Carrion.
Here.
Ms. Chang.
Here.
Dr. Chen. Dr. Diego.
Here.
Dr. DeRusso.
Here.
Dr. Israelian.
Here.
Dr. Levine.
Here.
Dr. Lowe.
Here.
Dr. Moran.
Here.
Dr. Solomonson.
Here.
Ms. Shipsky. Here. Mr. Zranian.
Here.
Ms. Yaroslavsky.
Present.
We have a quorum.
Thank you. So we're going to now move on to number 17, and that is the presentation of the Physician Humanitarian Award. The Medical Board is pleased to present 2 Physician Humanitarian Awards today. This award was created several years ago by this board to recognize the demonstration of excellence by an individual physician or group of physicians who strive to improve access to health care for the underserved population. So first, I would like to ask Dr. Richard Kammerman to please come forward and to be seated at this table here in front. Let me continue with my introduction. Dr. Kammerman is board certified in family medicine and is the past chair and current clinical professor of the UC Irvine Department of Family Practice. He graduated from the University of California Irvine College of Medicine in 1962 and was issued his California physician and surgeon license in 1975. Dr. Kammerman has contributed countless hours to service and leadership positions within the Orange County Medical Association and other professional associations and hospital organizations since the early 1960s. He has served as the OCMA's president and on its board of directors, and OCMA recognizes him as a Physician of the Year in 1997. He served as president of the Orange County chapter of the American Academy of Family Physicians and served as a representative to the California State Academy of Family Physicians and the California Medical Association. He has served on the hospital staffs of St. Joseph's Hospital of Orange, Children's Hospital of Orange County, and the Western Medical Center, serving as chair of the Family Medicine Department for each of these organizations. Dr. Kammerman has given his time to multiple volunteer and service groups, including the Discovery Science Center, the Santa Ana Junior Chamber of Commerce, and the Lions Club. He has received commendations for service from the Boy Scouts of America and the Orange County Board of Supervisors, the California State Senate, the California Assembly, and the House of Representatives of the United States Congress. I don't know when you have time to practice medicine. I just don't know. Dr. Kammerman's greatest humanitarian impact on the community has been the positive impact on the lives of the uninsured and the uninsured in Orange County. His tireless work and unwavering commitment to the poor resulted in an unprecedented launching of Cal Optima, the county's Medicaid-managed system of care. He oversaw the program's research and design and was instrumental in forging a partnership among the county government, private physicians, hospitals, community clinics that still continue to exist today. A few years ago, the Department of Family Medicine at UC Irvine created a Richard Kammerman Award, which is presented each year to a volunteer faculty member in recognition of outstanding service to the department and the community. Dr. Kammerman was the first recipient of the award and has continued to be named. It has continued to be named in his honor in recognition of his service, displaying the characteristics that form the selection criteria for this honor. Dr. Kammerman, it is our pleasure to honor and present you with the 2011 Physician Humanitarian Award of the Year. Please come forward to receive this. Let me hand this to you. I don't know which one has more issues walking, so it seems I've had the surgery, so I can. I'm trying.
Funny, good, yeah.
Well, thank you very much for this marvelous award. I humbly accept it. And I appreciate the support that everybody has given me in the past. I have been supported in the nomination for this particular award by the president of or chairman of the Department of Family Medicine, Dr. Catherine Larson. I have been also supported by the CEO of the Orange County Medical Association, Michelle Blair, and I've had letters from Dr. Marahashi and from the CFO and the medical director at Children's Hospital, Dr. Maria Mignon and Carrie Rupert. I feel that what I have done, I've done out of what I felt was necessary. I never did any of these things to receive an award or any special recognition. And I appreciate the generosity of presenting this to me. I'd like to attribute my compassion that I have developed for patients to the work that my parents did as volunteers in their community, and they set an example for me. I also feel that my journey to become an Eagle Scout and the Boy Scouts of America Award contributed to my character, gave me a sense of sensibility and integrity, and I think that the Boy Scouts of America had a large part in helping me develop my character, because I try to follow the laws of the Boy Scouts, which are excellent laws in my mind. I'd like to thank my wonderful family and loving family for the support that they've given me over the years. I know things were hard for them at times. They endured a lot while I was contributing to the community, to my profession, and to my hospitals and other services that I provided. I think that It's really remarkable that I should be able to receive an award like this. I just never expected anything like this, and I appreciate it very much. So I want to thank the medical board for considering this. I would like to also thank one other person who kind of put the application together, Dr. Beverly Parr. She worked so hard in putting this material together and filled the application, and rainy weather and everything went out and picked up the letters that were sent to you for recommending to me for this position or for this award. And I hold my hat off to her for all of the hard work that she did. There are other people that contributed to my help in me receiving this award. And again, I thank the medical board for issuing me and presenting me with this special award. Thank you.
Thank you. Would you like to introduce your family that's here with you today?
My wife, Karma, my loving wife, Karma. My eldest son, Gregory, and his wife, Stacy. Grandchildren are at school or work or whatever.
It's a good place for them to be. It's a good place.
Had to work too. He could not get away. Was there anybody else that I missed that I should be introducing? Representative from Dr. Cater from the Children's Hospital, representing Dr. Mignon and Carrie Rupert, and Steve is representing Michelle Blair from the Orange County Medical Association.
Great. Well, thank you very much, and our congratulations to you and your family, really. Thank you. Now I'd like to present the second award, and I'd like to, the second Physician Humanitarian Award, and ask that Dr. Rodney Borger please come forward and have a seat at this table. Dr. Borger is board certified in emergency medicine and director of the emergency room at Arrowhead Medical Center in Colton, California. He graduated from Loma Linda University of Medicine in 1993 and was issued his California Physician and Surgeon's license in 1994. He has dedicated himself to serving the Inland Empire for almost 15 years. He has repeatedly demonstrated his commitment to public health and safety through the development of innovations to improve the operation of the emergency department. Dr. Borger served on the California Department of Public Health Advisory Committee, which is charged with advising the agency on policies and procedures impacting California's health and safety, and to help improve that program's effectiveness in identifying emerging public health trends. In 2008, under Dr. Borger's guidance, a new patient flow system was devised for the emergency room that significantly shortened wait times and reduced the number of patients who left without being without being seen by a physician. Subsequently, representatives from many hospital emergency rooms, large and small, visited Dr. Borger to learn about the new patient flow system. Several months after the patient flow system was implemented, ARMC's emergency room was named the ER of the Year by the California Emergency Physicians of America. Dr. Borger was also instrumental in forming the San Bernardino County's Medical Reserve Corps, a specialized component of a Citizens Corps, a national network of volunteers dedicated to ensuring hometown security. Collaborating with representatives from several existing emergency response agencies, Dr. Borger assisted in the formation of a local MRC. Since 2003, he served on the MRC's He's served as the MRC's commander and has worked consistently to bring together the knowledge and skills of 120 health professionals and community volunteers to address public health crises. Dr. Borger's volunteer efforts are not just limited to California. In 1990, he traveled to Africa and provided basic health care for people in Botswana. In 2002, he provided medical care for missionaries and aid workers in the remote locations in Thailand. In 2005, Dr. Borger received the CMA Young Physician Community Service Award. In 2008, he received the Molina Healthcare of California's Community Champions Award and has since been recognized with additional awards for his leadership and impressive work. Dr. Borger, it is my honor to present you with the 2011 Physician Humanitarian Award. Please step forward to receive this award. Don't go too far. I'm coming.
I'd like to thank the board very much for this honor award. It means a lot to me, and I'm truly humbled to have received it. I did not know my hospital or medical society nominated me, and when I was in Home Depot getting a call from my office manager that the Medical Board of California wanted to talk to me, I was a little concerned, and I called back promptly. And as I was calling back, I was thinking, gosh, I know I got 2 speeding tickets in 3 years, but it can't be what they want to talk to me about. But I was actually honored and relieved to get the information that I was receiving this award. Without the support of great people, I could not do any of the things that I've done. I'd like to thank my family, my wife and kids. My wife couldn't be here today because she had to take my oldest daughter to an advanced placement exam that was only given once, I don't know, a quarter or a year or something along that lines. But without the support of my family, wife, and kids, of which I probably spend too many hours away from the family doing some of these things, I couldn't do what I do. I'd like to thank my partners and colleagues at California Emergency Physicians for their support as well. My office manager, Annette, Arrowhead Regional Medical Center, which is, in my opinion, the best public hospital in the state of California. My parents, Bill and Louise Borger, who are here, who always modeled volunteerism in the household. I can remember them doing more volunteer work in youth athletics than they did actual work, and they did lots of actual work. The Medical Society and the Medical Reserve Corps for their support. To be given an award from the Medical Board is a great honor, something that I've never sought. I try to work hard each day and try to serve others the way I would want to be served, sort of modified golden rule. This means not accepting that uninsured patients deserve less quality medical care than patients with insurance. They deserve the same respect and speed of care. Always going the extra mile to take care of my patients, ensuring that they get appropriate follow-up regardless of their ability to pay. Also being involved in education, residency training, PA education. Being ready to help the community and to be able to respond to disasters is also something very important that I've gotten to spend time doing. Also spending time with the Medical Society with political action I felt has been very important, but not to ensure doctors make a lot of money or anything like that. But the Medical Society, I think, is main focus, at least that I've had, is to make sure that the politicians and just protect the ability of physicians to practice medicine free from unnecessary bureaucracy. And I appreciate the Medical Board for doing its a very important job as well. I would like to thank the Medical Board directly. You have a very difficult task to protect the healthcare public, and thank you very much for your service. And again, I'd like to thank you very much for this honor. Thank you.
Thank you. Did you want to introduce your parents at least?
Yes. Bill and Louise Borger, my parents. Why don't you please stand?
Stand, please.
My daughter Emma, my daughter Annika, and my son William.
Wow.
Thank you very much.
Thank you very much. So we're going to continue with our agenda. And I'm going to ask for public speakers. Let's wait. We should go to enforcement. So what I'm going to do is, again, use some personal privilege, and we're going to move the agenda and go back to the enforcement committee, which you're all welcome to stay for, and then we'll go back to the board meeting. And I have the public speakers slips, so I will hold on to them for when we start again. Should I announce how long the meeting will take or not?
Good, just continue.
Dr. Lowe, I'm going to move. Whatever it's for you. I'm happy to move, Dr. Lowe.
Your chair there.
Why are we taking that out of context anyway?
You need it later.
Might have got to leave.
Okay, for any board members that are going to sit through this committee meeting, I appreciate it. Just remember that we would just appreciate comments from the committee specifically. If you want to tell me better. Wait, I've been instructed it needs to be done better.
In accordance with the Open Meetings Act, if there is a quorum of the board present, then the members who are not on the committee may participate only as observers, but may not comment.
Okay. I'd like to call the Enforcement Committee meeting to order. May we have the roll call, please?
Dr. Lowe,
Here.
Dr. Chen, Dr. Levine,
Here.
Ms. Shipsky,
Here.
Dr. Moran, Mr. Zarunyan. Here. We have a quorum.
Okay, the first item is that we're going to take public comments not on the agenda, and we have a slip submitted by Dr. Stan Furmansky. So I'd like to make sure that we limit these comments to 3 minutes.
Right. I have two items that are for the Enforcement Committee. At the last meeting, which was the January meeting, it was divulged that the University of California has been doing human research on some of the doctors you've been sending to San Diego. Under the Freedom of Information Act, we finally got documents to ascertain what was going on. The first one is from DHSS. It says here, has the project in human research been activated? It says yes. Is it active now? Yes. How many human beings do you plan to use? It says 400. Where do they get them from? They get them from the California Medical Board. Under research design and methods, it says all UCSD PACE participants are potential subjects for this human research study. Do you get the point? You're sending doctors to San Diego, and they're using them for human research. A third document under the Freedom of Information Act, just hot off the presses here, and this is from the horse's mouth. This is from the investigator themselves. It says, how many human subjects do you plan to use? They've used 400. How many do you want? It says 1,000. Where are you going to get 1,000 doctors to agree to do anything unless there's some element of possibly misinformation or coercion? That's one item, and you heard about that in January. This is documentation that it's all true. The second thing has to do with a totally different suggestion. As the Enforcement Committee, you have a policy of charging different amounts of money to different doctors. The probationers end up paying in a year roughly $4,000 in fees. Most of that is for what you call probation monitoring costs. In a period of 2 years, they pay $8,000. That's roughly 10 times what a regular doctor. As a regular MD doctor, I would pay $800 for a biannual renewal. However, if you're on probation, you pay 10 times as much. My suggestion to you is to consider this. You don't have to have, you can level the playing field by simply doing away with the probation monitoring. If you look at on the back table, there's a financial statement you just turned out today. That statement shows the contingency fund of the medical board is overfunded beyond the limits that the legislature allows you to have. You happen to have $10 million extra dollars above what the government allows you to have. Use that money in lieu as an offset of the probation monitoring costs. Level the playing field so that everybody pays the same amount of fees per year, and you do away with this 10-to-1 burden that you're putting on some of the doctors. They're paying 10 times as much as other doctors. If you did that, you could operate without charging the probation monitoring costs. You could operate that for 10 years, every year, for 10 years' time, and you would still be overfunded because you have so much extra money. Your accounts are burgeoning. The contingency fund has so much money it's even illegally overfunded now. That's all I have to say.
Thank you for your comments. Mr. Hepler.
Thank you, Dr. Lowe. The medical board has received a facsimile transmission to be read into the record for public comment. on practice monitors. I know there's an upcoming item on practice monitors. It's from Women's Advocate Jeanette Dreisbach. It essentially deals with two issues. Number one, she claims that, number one, the board's existing practice of how it assigns practice monitors is insufficient and needs to be revamped. And the second item is that the identity of a practice monitor is ripe for public disclosure and should be disclosed therewith. So the fax is incomplete. I believe there may be another facsimile, but I believe what we'll do in this case is we'll consider this to be read into the record as part of the public comment.
Okay, thank you, Mr. Epler. So there are speaker slips available in the back of the room. If you'd like to speak, please hand them to Ms. Threadgill. She's put her hand up. For those that want to speak on items that are on the agenda, please go ahead and fill out the speaker slip. You will be called at the appropriate time on the agenda. Are there any more public comment? Okay, there being no more public comment on the items listed on this agenda, we will now move to item 3, the approval of the minutes. Can I have a motion for the approval of the minutes from January 27th, 2011 board meeting? So moved. Is there a second? Second. All those in favor? Aye. Opposed? Motion carries. We will now hear an update on probation practice monitors from Mr. Kepler, Ms. Hayes, and Ms. Threadgill.
Thank you, Dr. Lowe. At the last meeting, it was suggested that perhaps one of the bars to participation as a practice monitor, too many moving parts for this thing, I guess, that there was insufficient, the reason for perhaps insufficient participation as a practice monitor was that there was a fear that the practice monitor may be the subject of civil litigation, and that this was chilling participation. The medical board provided me, through its probation unit, with some data, and as you can see in the memo, there's approximately 200 physicians that currently require practice monitors. And let me just say, practice monitors are installed as a condition of probation following a disciplinary hearing or a stipulated settlement. And my analysis is that it really wasn't, the fear of litigation really wasn't chilling the participation as a practice monitor. As you can see, most of the issue was costs or concerns about a HIPAA violation, problems finding a physician in the proper specialty, or I believe that the conditions and the actual conditions in the board's disciplinary guidelines require no existing relationship, a personal, social, or financial relationship between the disciplined physician and the presumed practice monitor. And that did present part of a problem because it may be a close network, it may be an office, everybody knows somebody office, it may be a small area, rural town, or whatever. But I guess the upshot of it is that the fear of litigation did not appear to be a significant contributor to non-participation. So at this point in time, it is the legal's office, your attorney's recommendation that consideration of extending a shield of civil immunity to a potential practice monitor is not really warranted because it doesn't appear to be the cause of the problem. So with that, I'll be happy to entertain any questions. But
so the program is revising the monitoring forms to recommend that a practice monitor seek and execute a hold harmless agreement. Is that right?
Correct. That is correct.
And okay, so that's good. So, all right, very good. Any public comment on this? Okay, why don't we hear now from Ms. Hayes. She's going to give us a presentation on the practice monitor improvements.
Good morning, Chair and members of the committee. Yes, my name is Catherine Hayes, and to my right is Ms. Rachel Lasota. At the January Enforcement Committee meeting, we presented to you the current process used by the probation unit for practice monitor condition. We identified some options to strengthen the performance of the practice monitors, which included, you'll see it on the slide behind me, exclusively using the physician enhancement program provided by UC San Diego, developing a pool of practice monitors who have been trained and approved by the board, using the current system, but develop and require the practice monitors complete a training course, or retain the existing system, but enhance the overall education provided to the practice monitors and develop a more structured program identifying the requirements. Next slide, please. After reviewing the options and assessing the board's current resources, it was decided that option 4 was the best choice based on the current staffing level and resources. We envision this process will not only strengthen the role of the practice monitor, but it will also provide more structure and guidance for the practice monitor. This new procedure will include an orientation given by the inspector to the assigned practice monitor, a detailed monitoring plan, a checklist for the site visit as well as the quarterly reports, and a sample to be used for the standardized reports. This will give the practice monitor a better understanding of what expectations the board unit anticipates. The inspectors will have a more active role in educating the practice monitor on what their function is and what information the board needs in order to ensure compliance with this condition. In the next few slides, we will review some of the new forms to be used to enhance this condition. These forms can be found in your board packet under the Enforcement Committee tab 4 behind the blue sheet of paper. Next slide, please. The first form is entitled Practice Monitor Nomination. This form is a new form that will be provided to the probationer when the initial contact letter is sent. If they have already identified a physician or several physicians, they can complete this form and provide it to the inspector at the time of their intake interview. If they have not identified someone, they can complete the form and forward it within the specified time frame to the inspector, which is usually 30 days from the effective date. Notice on the slide the enlarged section at the bottom of the form. This is highlighted to show you that language has been incorporated in this form to require that the probationer, quote, hold harmless the practice monitor, the State of California, Medical Board of California, its officers, agents, and employees from any liability associated with the practice monitor requirement. We are hopeful that this language will be approved by our legal counsel in order to provide the immunity or waiver protection for the practice monitor and others. Next slide, please. The second form is the pre-visit information form. This form will be completed by the probationer and provided to the approved practice monitor. The purpose of this form is to provide the practice monitor with a general overview of the type of practice setting and patient volume handled by the physician on probation. This form will also assist in the preparation of the monitoring plan as well as the site visit evaluation that will be performed by the approved practice monitor. Next slide, please. This document sets out the roles and responsibilities of the practice monitor. This document can be provided to the nominated practice monitor or monitors or after a practice monitor has been approved by the supervising inspector. The information contained in this document gives the practice monitor a perspective of what the probation unit is seeking to fulfill with this condition. Up to this point, the practice monitor has been nominated, approved by the probation unit supervisor, and provided with some preliminary forms and documents. When we get to this next slide, this is when the inspector meets with the practice monitor to provide them with an orientation. And I'm going to turn it over now to Ms. Lasota.
Good morning. Slide 6, please. The monitoring plan is a multi-page document. To view the entire document, it starts on page 98 in your committee packet. Some items we wanted to point out that have been added to this new procedure is the requirement for the initial site audit that is performed by the practice monitor on an annual basis. We believe that this will provide the practice monitor with more insight into the practice as well as the inspector. Another process that was changed is the number of charts that are reviewed in a quarter. Presently, the practice monitor reviews approximately 10% of the charts per month and submits a quarterly report that represents 30% of the patients, the total number of patients treated. We have found situations where the probationer may only treat 20 patients. With the current process, only 6 charts would be reviewed in a quarter. In our proposed plan, they would have to review 50% of the charts within the quarter, or in the example of 20 patients, it would be a total of 10 charts. With this new model, they will review 50% of the charts in a quarter when the physician has 20 or less patients, 40% if they have 21 to 40 patients, and 30% for 40 or more patients. The next page of the plan describes the selection process of the patient charts and explains the HIPAA mandates. It also provides the practice monitor with the timeline as to when the reports are due to the assigned inspector. The final page of the plan gives some information about the medical marijuana practices. Next slide, please. Page 101 of your packet. At the time that the inspector is conducting the orientation to the approved practice monitor, they will provide them with a copy of this agreement. They will go over each item on the agreement and have them initial next to the number that they understand what is required of them. The highlighted section in item number 2 will be selected based on the type of decision, whether it is a stipulated decision or a proposed decision. Additionally, it will describe the violation that resulted in the physician being placed on probation. The inspector will go over the accusation and decision with the practice monitor to ensure they have a full understanding as to why the physician was placed on probation so they can focus on this area when reviewing the charts. Item number 3 will be completed based on the pre-visit information form that was completed by the probationer. This is how we know the patient volume and percentage of patient charts to be reviewed by the practice monitor in a quarter. We ensure they understand the timeliness if they terminate their service, access to records, the monitoring plan, etc. And we have them sign this under penalty of perjury and have it witnessed by the inspector. Next slide, please. Page 103 in your packet. This document will be used by the practice monitor when they go to the probationer's place of practice to perform the annual site audit. Earlier, when we discussed the monitoring plan, it was mentioned in the plan that prior to the initial site audit, the practice monitor will be provided with a list of items to be observed. This is the document we are referencing in the monitoring plan. It provides some guidance to the practice monitor areas to observe. It will provide the practice monitor with a better understanding of the practice setting, and it will give the inspector more information about the probationer's practice. Slide 9, please. Another tool we developed for the practice monitor's use is the individual chart audit form. This form will be used when the probationer treats 1 to 20 patients. They will complete 1 form per chart file reviewed by the practice monitor. If the probationer has more than 20 patients, we have a similar form to this one they will use. However, it will allow them to put 5 chart reviews on 1 form. Next slide, please. This slide provides you with a side-by-side comparison of the current process and the proposed process. Some of the key differences are the requirement that the probationer complete a pre-site information form, the practice monitor perform an initial site audit of the practice, the monitoring plan is more detailed, the orientation provided with the agreement is more extensive, forms are provided to the practice monitor for the chart audits, and a sample report is provided. With these added measures, it will provide a more cohesive program for this term and condition without being overly cumbersome to the probationer, practice monitor, or the inspector. A suggestion was made at the last meeting that we survey past and current monitors to obtain information on concerns with the existing system. In reviewing background material on practice monitors, previous staff had conducted a survey. The following issues were identified. The amount charged by the practice monitor varies. However, most do not charge a fee. The average amount of time spent conducting the service is 2 to 3 hours per month. When asked if the board should provide a standardized chart audit tool, the yeses outweighed the nos. Some comments provided were that it would make it easier to look at each person on an equal basis and thoroughness would be ensured. It would make it more convenient and helpful, more uniform. However, on the other side, the comments were that each medical practice is different, difficult to standardize private practice, different MDs do things differently. When asked if the board should be put together a basic practice monitor training course, again, the yeses outweighed the nos. Some of the comments were that a basic practice monitor course is necessary, will be helpful especially for the first time, standardize the process, etc. Some of the comments against the course were not necessary if the right monitors are selected. You can't teach personality and mentoring in a class. Most of it comes naturally with experience. See no need for it, not necessary. Lastly, they asked what recommendations could be offered to improve the Practice Monitor program. Some comments were, a little more guidance in what should or should not be in quarterly reports. Give us a package with instructions. Use or model the UC San Diego Physician Enhancement Program training and audit forms. In reviewing these comments, we believe that we have addressed many of the concerns identified in this survey. We want to put the new procedures into production and reevaluate after 3 to 6 months to determine whether another survey is indicated. In some instances, the practice monitor condition has been ordered in cases where the physician has a substance abuse issue. We intend to start developing a concept of utilizing a worksite monitor whose roles and responsibilities will be different than performing chart reviews and worksite inspections. We hope to bring this issue back to the committee in the future. This concludes a preview of the new forms that have been developed. Once our legal counsel review has been concluded, we will plan to put this new process into production. We will follow the progress of the program and report back to the committee once there is sufficient feedback on the new process. Do I have any questions?
Thank you very much, Ms. Hayes and Lasota. That was a really excellent overview of the practice monitoring program, and I think there are clearly very important enhancements, and hopefully our legal department will approve those changes and we can implement them and have a better program. Thank you very much. Are there any public comments on this issue?
Board comments?
All right. Being that there are no...
Dr. Lowe?
Oh, yes.
Thank you. That was really excellent and thorough. One question is, do we know how the probationers go about identifying and looking for practice monitors?
It varies, and that's one of the inconsistencies that we run into in the field, because many physicians that are placed on probation that have this requirement, they have contacts in the same field, but they're embarrassed to approach them. And so that sometimes is a delay in getting a monitor. Many times it's people that they went to school with years ago that they know that they're in that field, and that's how that contact is made.
So at the last meeting we talked about trying to develop a pool of probation monitors, and I think that would work out the best. But you know, there are a lot of different areas, and so we have to have a big pool because people have to have an expertise in that particular area.
And I wonder if, the folks from CMA aren't in the room, but I wonder if the medical association, the county medical associations could at least publicize what the practice monitor does and how people could nominate or indicate their willingness to serve as a practice monitor and serve as a reference for probationers in terms of looking for names in the broad geographic area.
I think that's a good suggestion, and maybe the medical board can appeal to the medical societies.
And then just one other slide, we just wanted you to meet the probation unit, and these are all the inspectors throughout the state that oversee doctors and other surgeons and so forth that have been disciplined. Thank you.
Thank you very much.
Dr. Lowe, no, I can...
Renee, somebody has their hand up. Can you see if they have a slip filled out?
Well, Dr. Lowe, I'm on the board. Can I
Yes.
ask a question? Thank you.
Ms. Shipsky.
We're down here on the south right side of the thing. Two things. Thank you very much for the presentation. It's excellent, and I think it helps outline the very specific things that go on, because I know in looking back at the previous minutes, several of us had asked some questions. Just two suggestions. On page 2 for the practice monitor pre-visit sheet, one of the things that you ask is who the physician utilizes in his or her practice, and you don't have the category for nurse practitioners or midwives. And I think that would be very important, particularly because we obviously see sometimes in cases about supervision of allied professionals. And then on the assessment, this has come up repeatedly in our advisory committee on supervision of allied personnel, that there needs to be in place written standardized procedures. And so I think it would be very helpful that if that monitor is coming into that practice and that practice does utilize others to actually perform procedures, that there be evidence of written standardized procedures. In fact, that came up yesterday when we were talking about how does anyone enforce the requirement that you have them. This might be a start, because sometimes, as we see in some of the cases, it is things are done verbally, and there may not be some written direction, and this would be a requirement to see that's in the practice. It's the best practice model. Thank you.
Ms. Shipsky, when the inspector conducts the initial, when the inspector conducts the initial, what we call the intake interview, meaning that the effective date it has occurred for the probationer to start probation, one of the things that the inspector does ask is, do you have written protocols for the staff, whether they have RNs and so forth?
Right.
So
I didn't see it on the sheet.
it's not on the sheet. We will look into it, but I wanted to assure you that it is asked during the intake interview.
Right, and there actually should be some evidence of an agreement between the PA and the physician, or the mid-level and the physician. That's a requirement that they have evidence of that.
Okay, thank you.
I just want to clarify also that protocols are different than standardized procedures. There are specific conditions in the regulations for standardized procedures that are different than whatever protocols an office might have.
Yes, Mr. Zuranian.
Dr. Lowe, thank you very much. Ladies, thank you for a great presentation. The only thing that I want to ask is, have you thought about, or is there a form of a matrix that you'll develop as a result of this to see the effectiveness of what you've done? Because it does change, certainly, the practice from your perspective, certainly. But I think the board would need some form of an evaluation of the new forms, and maybe you can develop a matrix where you can report back to the board another day to let us know how effective this is. Because I think we always need to be developing these good ideas and seeing how effective they are. And we don't want to be a burden or a bureaucracy without any purpose. And such a matrix would give us that purpose. Thank you.
Okay, thank you. We have one public comment, Tara Kittle. And I would like you to limit your comments to 3 minutes.
Copy that. My name is Tara Kittle. I was just listening to the presentation, and I agree that I feel that the committee is taking a positive step in regards to developing a consistent program in which to approach physicians who are in probation. What I would encourage, an idea that was actually just sort of mentioned, is developing a concrete system in terms of what the expectations are of physicians while they're practicing medicine, so that there is a clear level of expectation that's being required. As was mentioned, is sometimes everyone does things differently. And I was thinking about why this meeting runs so well when the practice of medicine right now on the front line is such a disaster, and there's so much disrespect between patients and physicians to patients. And what I realized, what makes this meeting work, is because there's structure, there's order, there's clear expectations, and it's being recorded. So I would just encourage, while you go through this journey of establishing probation requirements, that you also examine in general in terms of the structure of the actual patient-physician relationship.
Okay, thank you for your comments.
Dr. Lowe, before we begin, I just want to point out that Ms. Dreisbach's comments would be appropriate. The written facts I spoke of in public comment would be appropriate to this agenda item as well.
Thank you. No further public comment. Let's move on to the next agenda item. The next agenda item relates to expert reviewer utilization. And Ms. Threadgill is going to give the presentation on the central complaint unit.
Thank you. As a result of the restriction, the executive order restricting travel, the intended presenters for, as shown on the agenda, were unable to be present. Therefore, I ask you to bear with me as I stumble through their presentation. Next slide. The Central Complaint Unit is responsible for performing the intake review or triage on new complaints filed with the medical board to identify those which warrant formal investigation. Business and Professions Code Section 2220.08 requires that before a quality of care complaint could be referred to the for formal investigation, the complaint must be reviewed by a medical expert practicing in the same specialty area as the physician named in the complaint. This statute went into effect in 2003, and since that time, the complaint unit has increased the size and composition of their expert pool from about 15 general practice physicians to approximately 184 physicians in a variety of practice specialties. Next slide. The experts are hired as independent contractors, similar to the expert reviewers used by the field, and are compensated at a rate of $75 per hour for their review time. The selection criteria used by the complaint unit is very similar to that required for the expert reviewers in the district offices. Essentially, we look for a physician with an active license with no complaint or disciplinary history and ABMS specialty certification. The complaint unit can be less stringent with the requirement related to active practice and can accept physicians who have retired from practice depending on how long they've been out of active practice. Next slide. When applications are received for expert reviewers, staff performs a background review, and if no detrimental information is identified, the physician is appointed to the CCU Central Complaint Unit expert pool and provided with a training manual. We typically send several cases for review shortly after the training material has been provided, and then contact the reviewer by phone to walk the reviewer through the process. Next slide. Cases are prepared for expert review by staff in the complaint unit. Staff will collect all relevant medical records and contact the physician named in the complaint to request a written summary of the care and treatment provided to the patient. Physicians are not required by law to provide a written summary. However, the board is required to give the physician the opportunity to respond. Once relevant information has been gathered, the entire complaint file is referred for an expert review. Next slide. The complaint must be reviewed by a medical expert practicing in the same specialty area as the physician named in the complaint. Staff in the complaint unit will review the CCU expert reviewer list to identify an expert available to review the complaint. We've included a chart which reflects the composition of the current expert pool. There are approximately 184 physicians in a variety of practice specialties, which may sound like enough experts. There are some practice specialties that are underrepresented, and cases can be delayed as a result of waiting to find an appropriate expert for review. Next slide. After reviewing the complaint file, the medical records, the expert prepares a written report of their findings. The expert will indicate that either the complaint represents no departure from the standard of care, simple departure from, or recommends that the matter be referred for further investigation to one of our district offices. If the expert finds no departure from the standard of practice, the complaint is closed by CCU and retained for 1 year. If the expert finds an error or omission in the physician's care that represents a simple departure from the standard, the complaint is also closed in the complaint unit but retained for 5 years. Finally, care that potentially represents an extreme departure from the standard is referred for formal investigation. We have included several statistical markers to give you an idea of the volume of cases reviewed by the CCU expert reviewers and the average time frame to complete the reviews. Next slide. Now, I would like to describe how the field utilizes experts. Next slide. The qualifications are similar to the CCU experts, except the
Ms.
expert
Threadgill,
must...
you're one slide behind.
I'm one, but what happened here? Okay. Next slide.
There. Let's go.
The qualifications are similar to the CCU experts, except the expert must have an active practice where they work at least 80 hours per month. 40 of those hours must involve direct patient care. Next slide. This is our most recent guideline book that each expert has as a reference tool. Next slide. The expert's review is typically the last part of the investigation. The investigator's job is to gather enough information that the expert can make the best opinion possible. Next slide. Investigators utilize a database that lists experts by specialty and subspecialty. Once the investigator selects a potential expert, they can review comments that other investigators, medical consultants, or attorneys who have used this expert have made. Each experts who receive poor ratings may receive remedial training, or they can be removed from the program entirely. Investigators or med consultants interview the prospective expert. The checklist, next slide. Next slide. The checklist, next slide. I'm a little out of sync, so they utilize a checklist which includes confirmation that the expert understands their role, that there is no conflict of interest, that they understand the correct terminology, and that they have expertise to render an opinion about the issue at hand. These are the reviews an expert package receives. Because there is potential to bias an expert and make an opinion that would not be useful, several people review the package to make certain it's perfect. Next slide. There is a requirement for investigators to follow up with experts every 3 weeks after the delivery of the package. Ideally, we want the opinion within 30 days of the expert package being dropped off for review. Since July of 2010, out of 299 records, the average number of days is 47 from the delivery of the package to receipt of an opinion. This is a pretty good statistic. Some cases are extremely voluminous, so we allow...
Slide. Can we go to the next slide, please? There. Thank you.
So we allow extra time for those cases. We also utilize experts from our database for the functions that are shown on this slide. Oral competency exams.
Advance 2 slides.
Next slide. Oral competency exams, mental and physical exams. Next slide. Once the opinion is received, it's scrutinized by many: the medical consultant, the expert, and the deputy attorney general assigned to the case. Next slide. These are the most troublesome problems with the expert opinions we receive. I'm hopeful the training we are working on will resolve most, if not all, of these issues. Next slide. These are the findings an expert can make: no violation, simple departure, or extreme departure. It's the expert's opinion that determines the outcome of a case. Next slide. After the opinion is received, the investigator and the medical consultant rate the expert on a variety of criteria. If the expert testifies, the Deputy Attorney General also prepares a evaluation.
I think it's important for folks to understand that the evaluation is not based on whether the board wins or loses.
No, it's done after the report is written and received by the board. The med consultant and the investigator do their evaluation at that time, so it's definitely not based on the outcome of the case. Next slide. These are what the evaluation forms look like. They speak for themselves. Next slide. Next slide. That's essentially it. Are there any questions?
Okay, that's a wonderful overview of the work that the enforcement unit does, and I think that it's very comprehensive, it's very structured, there's a lot of checks and balances built into the system, and there's a system for ongoing review of the experts that we actually utilize. Are there any comments from the board members? Public comment, we have one slip submitted from Rehan Sheikh.
Thank you, Mr. Threadgill, for the excellent presentation. Like Dr. Lowe said, there are excellent checks and balances. So my question is, you have excellent requirements laid out for the expert physicians. When you receive a complaint, it goes to the specific physicians who has a requirement for 80-hour practice and other several requirements that you mentioned. So, I mean, how do we ensure that you are actually complying with those requirements? I mean, by mistake, if you happen to overlook those requirements, is there any check on your judgment?
I think this is, this is not a question and answer period. It's for public comment.
Dr. Lowe, I just want to know what are the checks and balances. If they miss something, is there any requirement? And according to the Business and Professional Code, it's a simple question. It's not an argument. You can consult with your attorney.
I don't understand the question.
Are you refusing to answer my question, sir?
I'm sorry, Mr. Sheikh, what is the question? Because
so what are the checks and balances? My question is to the board members, sir. Okay, so I mean, who are the board members and will ensure that the executive staff is complying with the procedures, or will it be Deputy Attorney General or Attorney General who will ensure that the staff is complying with the procedure?
Well, the complaint unit has the interaction of the medical experts, the investigator, as well as the Attorney General's office, and all of those function as the check and balance system. I mean, when they're very sure before they take a case and proceed with it. So, I mean, that is the built-in checks and balances. Okay, let's proceed. Any additional public comment? No further public comment. Let's move on to the second part of that presentation, which will also be given by Ms. Threadgill.
Turning to agenda item 6. Again, because staff who were designated to present as shown on the agenda are unable to be here, I will attempt to provide you with their presentation. At the last Enforcement Committee meeting, staff was requested to examine all processes used by the board to investigate complaints with the goal of identifying opportunities for process improvement and reducing investigative timeframes. We have identified 4 major complaint categories from the annual report and prepared a flow chart identifying each major step or activity from the initial intake review through the investigation to either closure or referral for administrative action. Data was generated from the enforcement tracking system, which is CAS, to identify the average number of days to complete each step in the process for each complaint type. The average number of days has been posted to the flow chart by the appropriate step in the process. The data produced reflects only those cases which were open and the step was completed between January 1, 2011 and March 31st, 2011. The average time frames presented in this initial report contain a relatively small data set, and the number of records used to calculate the average time is displayed on the chart. I'm presenting this material to the committees. However, I would like to provide at the next meeting a larger data set so that we can have a truer picture, a truer reflection of the current average processing time for each step in the investigative process. And I can then also compare prior years for the same data set for comparison. At the if you've all had a chance to look at it, I'd like to ask if there are questions at this time about the data.
I trust everybody's had a chance to review these flowcharts. I'm incredibly impressed with the work that went into making these industrial engineering type flowcharts and the dates that are associated with it. It's pretty impressive, and we look forward to your further analysis with the larger numbers. I think that'll be very important. So I don't think there are any questions from the board members, and why don't you go on? Is that conclude that portion of the presentation?
Well, I can point out some anomalies in there if you have a moment. I was trying to move this, recognizing that we have limitations on our time.
Well, I think the flowcharts are pretty detailed and pretty self-explanatory, and I think we can move on. If there are no public comments, we can move on to the final agenda item.
Okay.
Okay, let's move on to that. And so the final agenda item is the enforcement process data markers and timeline. And again, Ms. Threadgill is going to go over that. Is that right?
Yes. That was, we just looked at the front end, the first set that you see, but then it has the continuation of both the complaint unit and the enforcement together. It's just that Laura was doing one set. I sort of combined them all together in the one agenda item.
Oh, I see. Okay. All right. So, I mean, I think those numbers are quite respectable for the recent data. So we look forward to the further analysis.
Okay.
Any comments on that? Okay. So let's move on to the final agenda item, and that is any topics for discussion at the next meeting. And there may not be a next enforcement committee meeting at the next medical board because of time constraints, so it may be the following meeting. But we'll certainly put any recommendations on the agenda for that meeting. Any of the board members? Yeah, Frank?
The only clarification I seek, Dr. Lowe, is you want us to look at the flow chart and the dates and then express back to you the concerns that we may have so that we may agendize this, or what are you asking us to do?
I think that the data sets are relatively small in that, and they're going to come back with an analysis of a larger number of cases, and I think at that time we can maybe look at it more closely and come back with questions for the following meeting. Does that seem reasonable?
Well,
I mean, because these numbers are too small, and anything that we might raise probably won't have significant meaning until we get more numbers.
Okay, well, that's fine. But I mean, this chart and the days that we have remains under scrutiny as far as I'm concerned, and I want to keep it on the front burner, in other words, is what I'm saying.
Well, with these limited numbers, these days aren't really out of line. I think they're quite respectable, so.
This is an item that we will include in the enforcement package at each meeting. However, I just wish to refine it a bit more because, for example, there are several anomalies that show up when you have such a small data set. In the acquisition of medical records, which in the enforcement side, it shows 145 days. Well, that was of concern, and so when you look at the records that are in that group and go to the individual cases that make it up, we found that one case was a subpoena enforcement action. One case was a case where we didn't receive the records for over a year, so it skews the average. So I'd like to have a better data set to evaluate, so to sort of get rid of some of these anomalies.
So, Mr. Zeranian, even if we don't have a committee meeting next time, she can include it in the enforcement report, and I think that'll satisfy everybody.
Yeah. Well,
okay.
It certainly would satisfy me because I want to make sure that this topic remains before us, and that it is looked at, especially now that we're starting to identify where the issues are and the dates are, because the next items perhaps that'll come from that is how can we change those and what can we do to improve those dates, because I certainly personally right now I'm not still satisfied with the dates.
Sure. I think we should never be completely satisfied. We should always strive to do better, and I think that's the goal of the medical board. And so I think the next time when you put together the data, it's important to put the data together with and without outliers, because outliers can really skew the data, and if we can identify those outliers and say why they're outliers, then the data will have a lot more meaning.
So for clarification, do you want this to be under my enforcement report or for the enforcement committee agenda package?
If we don't have an enforcement committee meeting next meeting, then let's include it in the enforcement report.
Okay.
It can be brief.
Dr. Lowe, yeah, I absolutely agree. I think it would be very helpful to us, and also since these are public documents, that we do get the data that indicates the outliers, because I think that if you have cases very specifically where we can get a little bit more narrative that indicates, why that case took an exceptionally long time, I think that would be helpful, very instructive to everyone.
Okay, thank you.
All right.
No further agenda items. Let's go ahead and move for adjournment. Motion. So moved. Second. All those in favor? Meeting adjourned. Thank you.
But don't go anywhere. I'm going to call the full board back into session. And given that it's past 11:15, when we are supposed to go into executive session, which is a closed session to deal with a case, item number 21, and then lunch, we will resume around noon for the presentation by CMA and the continuation with the agenda. Okay, so closed session will be short. well as the board for their indulgence in the scheduling changes. And I'm going to ask for, we'll start with number 2, public comment for items not on the agenda. I want to remind anyone that wants to speak, they have the 3 minutes. It is not to be about anything that we're discussing as a Medical Board of California, as well as it is not a conversation. It is only an opportunity for you to have your 3 minutes at the table. So I have a slip, but it's not on what from this gentleman. I have a slip from Tara Kittle. Did you want to speak at this time, Tara? 3 minutes. Yeah.
My name is Tara Kittle, and I'm a healthcare consumer. I just wanted to thank you all for welcoming me back, and it's nice to be back, even though maybe the circumstances aren't the greatest. What I've written for you is a list of ideas that to help improve the medical system. Most of these ideas don't actually cost the state any money. These ideas have been born out of my experience over the last 3 months. I've spent the last 7 weeks hospitalized in 3 different Los Angeles area hospitals. And through those experiences, I have observed and witnessed a number of areas in which we as the medical board can take steps for improvements in our economy where funds are lacking. Skipping ahead to the pink pages, ways to improve healthcare that don't cost the taxpayers any money. Number 1 is audio taping their conversations. I know this seems sort of maybe not normal because it's not something currently done, but just as we audio tape conversations here, it allows for accountability in both parties. So both the physicians that are helping the patients are protected from patients who may later claim to have not remembered something, and then the patients have protection in regards to accountability for what happens to them. I don't even want to get into some of the things that were said to me, and like no one would believe if, you know, some of which I have recorded, but some of it I don't. And I really believe deep within my heart, since the medical board cannot be in every doctor's appointment with every patient by audio taping, and just creates this feeling of accountability between both parties. I wrote an example of a patient rights and responsibilities that could be given to every patient who comes through the office. This is both, again, rights and responsibilities for their role. The other thing that would help would be to abolish hospital admin boards, as well as insurance company physicians who say no, because saying no to a doctor's orders is altering the course of medical care. And
Tara, you're going to need to wrap it up. I'm sorry.
That's okay. Basically, what I'm asking you to do, the most important thing is was the first thing, the financial compensation structure for physicians, that basically physicians need to be paid for the work that they do. And right now they're being legally accountable for things like reviewing patient records, making phone calls, and they're not being paid for that work. So what's happening is fewer and fewer physicians are going into family practice, and then more and more physicians are being forced to cut corners. So what I was asking is for the board to consider putting that on the agenda for further discussion, setting up some kind of payment compensation committee to actually go over and review the structure to sort of help patient outcomes.
Thank you. Thank you very much. Dr. Stan Formansky is not present. John Marshall.
Good afternoon, everyone. My name is John Marshall, and I was on disability and had private disability insurance, and still do actually, but I was sent by my insurance company to an independent medical exam in 2007, and after the exam received a 40-page write-up which included tests, measurements, examinations that were never done, and the report was essentially a total fraud, but the insurance company used it to deny my disability benefits. On the heels of that, I made 3 complaints. one to the radiology board, who found that the doctor was using an unlicensed technician to take my x-rays. Two, I also contacted the HIPAA people, the federal government Office of Human Services, who found that the doctor was illegally withholding my medical information, my medical records from me, and forced him to hand them over. And I also went to the medical board, which did not do any investigation whatsoever. Now, since then, I've also found that the same doctor has been doing, essentially been repeating the same format with other patients. He essentially duplicates the exact same results they gave to me with other patients and turns that into the medical, to the insurance company, so they can use that to deny benefits. He's also been using the same medical or same X-ray, unlicensed X-ray technician to take X-rays of other patients as well. So this has been an ongoing problem with this particular individual, and because of this insurance company, I've been sent to 2 other IMEs, and exactly the same thing has happened. So I've evidence of multiple violations and what people would call felonies by this same doctor, and also by other doctors as well. And I haven't found that the medical board has showed any interest in this particular item whatsoever. And when I've gone to the Attorney General to report it as well, they asked me, why has the medical board not done anything? And I said, I don't know, and I still don't know why it hasn't done anything. But they also said that the violations that the radiology group has written up on this doctor should be part of his medical record that the medical board presents to the public, and so far that hasn't been done.
Okay, thank you. My understanding is you are in communication with our staff, so I want to thank you for that, and we'll move on to the next person. Thank you. Dr. Aslan?
Well, first I would like to thank the medical board giving a chance to our side of the story to be listened. I am an 88-year-old physician, internal medicine specialist, and I have been in the internal medicine department of the Santa Monica UCLA Medical Center for 27 years. And then I retired in 2009, but still continued to practice in Brentwood part-time, a few hours a day. Because I like to be helpful to the patients rather than traveling various countries, cities, going there, going here. Those kind of things didn't attract me, but to be helpful to the patients all my life, rest of my life, until my health doesn't allow me to practice. Anyway, I had a little problem with the medical board. A patient, lady who had many problems and in a menopausal age, had one divorce, having another divorce, having problem in that divorce, and had a teenage daughter. She was very unruly and even sometimes hitting the mother with broom. That kind of lady one day sent a letter to medical board. By the way, I saw her about 6-7 years for chronic pain problems, breast enlargement thing that went wrong, and rheumatoid arthritis and menopause. So he sent a letter to the medical board that Dr. Aslan gave me excessive medicine. And
let me just let you know you have about 30 seconds. You need to wrap this up, please.
Beg your pardon?
You have 30 seconds, so you need to wrap this up, please. You need to bring this to conclusion, your public comment.
My son catch up.
You have 3 minutes to speak, and you already used
Yeah,
2
okay.
minutes.
All right, well, anyway, the reason, she said, when I called her, why you complained? And she said, well, Dr. Aslan, I wanted to discontinue this medicine, but if I complain to medical board, you will not give it to me. I said, well, you should tell me. If you didn't want, I could help you even how to go without taking this chronic pain medicine. Anyway, then medical board investigator called her several times, asked her to come to the Glendale office. She would never cooperate, come. In other words, she wouldn't respond to medical board's investigators' attempts. Yet medical boards called me. We had an interview, and physician, Dr. Pollack, couldn't find anything with my problem. He asked to the investigator, well, I would like to take another doctor to take a look to Dr. Aslan's thing. And then they couldn't decide. They couldn't find anything I did wrong, but then they sent a letter to UCLA to hiring their 2 young physicians to review my 7 patients of charts I gave to them when they
Okay,
asked.
Dr. Aslan, I'm going to have to cut you off. I'm sorry you've had more than your time, but thank you for your comments.
Well, anyway, I would like what I would like from this board. When I say one thing, what I want from this board, please. I am 88 years old, and I had my revoke almost 6 months. Suspended 6 months from practicing. So, please, first, whenever you meet again, or whenever panel meets, let me be heard my case there. I would like to.
Thank you very much. Thank you.
Madam President, members, let me just say that as your legal counsel, to lift it, the medical board has lost jurisdiction over this case that resulted in the revocation of Dr. Aslan's license. We have no jurisdiction over this matter to test the sufficiency of the decision. That is left to the civil courts, to the Superior Court. Any attempt to reinstate his license must be done through the appropriate process.
Thank you, sir. So continuing with public comment not on the agenda. Can move to Genevieve Claverall. I did better yesterday because you wrote better yesterday.
Good afternoon. I'm just wanted to know what's the standard for a doctor's order written in an apothecary system. And I thought the apothecary system went way away in the past. And to my surprise, recently I saw some doctor's order written in an apothecary system. And when I asked the nurse to define for me the amount, did not know how to calculate the apothecary system. So in the state of California, is it common practice for physicians to still use this archaic system? And maybe you can point me in a direction to see if somebody has some information on that. Because if the nurse can calculate it, that's quite dangerous.
Thank you.
I have given the public speaker my email address and asked her to correspond with me with any questions you have. I can answer those offline.
Thank you. We're going to move to, I don't have any other public comment speaker slips that are for items not on the agenda, so I'm going to thank those people and move on the agenda. We're going to move to number 23 and hear from Carrie Wiesel. If you would come forward, please.
This item on page 216 of your agenda packet has to do with the proposed written guidance to pharmacies and prescribers on the transmission and receipt of electronic controlled substance prescriptions pursuant to the Drug Enforcement Administration's interim final rule. The Board of Pharmacy asked us to work together in developing a simplified information booklet to the physicians as well as the pharmacists. 2 Deputy Attorney Generals got together and worked on this, and I'm going to turn it over to Deputy Attorney General Carrie Weisel to go ahead and present on this item.
Thank you. The summary that has been provided to you and that is proposed to be included on the Medical Board website is this better? Was prepared by Deputy Attorney General Joshua Room and me in response to requests by the Board of Pharmacy and the Medical Board. The final interim rule on electronic prescribing adopted by the DEA is very complex, and I have to admit that the summary is pretty complex as well, but it does make it more accessible and was compiled from the rule itself, the regulations, which have been codified in the Federal Code of Regulations, and from materials that have been provided by the DEA's the Office of Diversion Control, which has an excellent website that you may want to try to link to on the Medical Board website. It has FAQs. There's a PowerPoint presentation, and a lot of questions are answered there as well. Much of the answers for those physicians who want to engage in the electronic prescribing of controlled substances will be answered by the application providers who provide the software. They're the ones that can direct the physicians, and that's noted in this summary. The summary, I think, will be helpful to practitioners. First, some may not even be aware that it's now acceptable to the federal government for controlled substances to be electronically prescribed. And second, to help them find out how exactly to go about doing it and where the answers are. This particular summary is helpful also because it discusses to some extent the interaction between the DEA regulations and California law. So I would recommend that you do put this on your website to assist physicians if they choose to electronically prescribe controlled substances.
So what I'm hearing is a request for this board to accept your report. Is that correct?
Yes, it is.
Okay, do I have any questions for the presenter? Any public comment on this presentation? Can I have a motion to accept the report as delivered?
So moved.
Second?
Second.
There's no discussion, so done.
Thank you.
Okay, moving back to item number 3, with the approval of the minutes from January 28th. May I have a motion to approve, please?
So moved.
There's a revised version of the minutes. Okay, everyone's seen the revised version of the minutes, so I want an approval of the revised version of the minutes, please.
So moved.
Do I have a second?
Second.
Any public comment? Any comment from any of the members of the board? All those in favor, please say aye.
Aye.
Any opposed? So that is done. Moving on to number 4 on the agenda, I would like to ask Mr. Warden and Mr. Hepler to please come forward so we can start the public hearing. And I will then begin the public hearing process. Good morning. My name is, or good afternoon, sorry. good intentions. My name is Barbara Yaroslavsky, President of the Medical Board, and I will be presiding over these hearings. Today we have two rulemaking hearings scheduled, so I don't have to repeat myself each time. Let me discuss only once the format that will be followed for this hearing. Then we will move into the two individual hearings. We ask that persons in attendance print their name on the roster at the room's entrance. If you wish to testify, please fill out a speaker slip and give it to staff. The purpose of each hearing is to receive oral testimony concerning the regulatory proposals described in the notice. Regulations must comply with 6 legal review standards, which are necessity. Is there demonstrated evidence that there is a need for this regulation? Authority. Does the board have the legislative authority to adopt the regulation? Consistency. Does the regulation conflict with other regulations or statutes? Clarity. Can the regulation be easily understood by those affected? Non-duplication. Does the regulation duplicate other regulations or statutes? And reference. Which statute does the regulation implement, interpret, or make specific? Testimony should only address those 6 standards. Before we begin, I would like to briefly describe the procedures that will be following each hearing. Each hearing will be taped. Those persons testifying will not be sworn in nor cross-examined. All recommendations and objections will be considered by the board members. Responses to all objections or recommendations will be included in the final statement of reasons. The board will maintain a rulemaking file for this proposed regulatory action. A completed copy of the rulemaking file will be available for review at the medical board's office in Sacramento. To ensure fairness and that everything is completely entered into the record, and to enable everyone to hear those who are giving testimony, we ask that those testifying follow these procedures. Speak loudly and clearly. Identify yourself and who you represent. Please state your position, support or oppose, at the beginning of your testimony. Oral testimony will be limited to 5 minutes per person. Any written, please do not repeat any testimony already heard. And any written comments you have with you today should be summarized orally but not read. As mentioned, we will have 2 hearings scheduled today. We will hold the first hearing, take testimony, and close the hearing. Then the board will discuss the matter and a vote will take place. Then we will move into the second hearing. Now let's move into the first hearing. Mr. Hepler, Mr. Warden, please.
Thank you, Madam President. Members, if you recall, this action came to us by way of a direct petition by the City of Hope asking for a slight change in the existing regulation, Section 1327 of Title 16 of the California Code of Regulations, requiring accreditation. And it's a slight change due to the bylaws of one of the accrediting agencies. It's impossible for the City of Hope to become accredited because they are accredited, as I understand it, by the CMA, California Medical Association, which precludes accreditation by the Accreditation Council for Continuing Medical Education. This proposed regulation, besides making a few conforming changes, would allow a clinical training program, still subject to filing an application and approval by the board, to be approved by either the California Medical Association or the Accreditation Council for Continuing Medical Education. That is about the sum and substance of the regulation, and I'm more than happy to yield to any questions or hear from the public.
We have received written comments in support of this from the City of Hope that I don't need to read, and we'll go forward. Continue.
Madam President, members, we have also, as my understanding, received written comment from Ross University that about an issue in existing regulation that is not really germane to this rulemaking proceeding. It has to do with the contents and the construction of some of the existing provisions of Section 1327 and need not be considered in this rulemaking procedure.
Okay, then it won't be. Do I have any other requests for the opportunity to speak on this? Mr. Warden, did you want to?
This just provides the opportunity for the City of Hope or other hospitals that are in that similar position to provide clinical training if it's approved by the board to medical students.
So can I have a motion to adopt the proposed changes, please?
So moved.
Do I have a second? Do I have any questions on the motion as it stands from the public or from the board members? So all those in favor of the motion as it stands, please say aye.
Aye.
Any opposed? Thank you. So done. So we'll start with the second hearing, please.
A bill was passed last year that took effect this year that permits practitioners who are licensed in a state other than California to provide services at a healthcare event in California. You have you approved the setting of these regulations for hearing. This would implement that statute. I will point out, because I'm going to ask you to make a somewhat complicated motion, there have been no comments received on this item. We have in your packet some modified text, and that is the text that I would like you to look at. It is in double underline and strikeout. It was, I believe it was a handout.
Yes. Should we hand out modified text?
If you're having difficulty finding it and you want to look at the original text, I was going to go through the substantive changes that are included in the modified text, so let me know if that's what you'd like. Okay. The proposed regulations would define what a community-based organization is, who an out-of-state practitioner is. It would also set forth the sponsoring entity registration and record-keeping requirements. And in that section, which is proposed section 1333.1, in new subsection D, there would be the notice to consumer type of notification, where a sponsoring entity, and this is the sponsoring entity itself, has to place a notice visible to the patients at every station where the patients are being seen by a physician and surgeon. The notice would be in at least 48-point Arial font and shall include the following statement of information. Notice: medical doctors providing healthcare services at this health fair are either licensed and regulated by the Medical Board of California or hold a current valid license from another state and have been authorized to provide healthcare services in California only at this specific health fair, and then it would have the medical board's contact information. That's the first change in the modified text. The next change shows up on page 175.3 of your booklet under section 1333.2, and we moved the costs for the criminal records check from the beginning of the paragraph to the end, and also made it clear that an applicant shall pay the cost for furnishing the fingerprints and conducting the criminal history record check, only applying to the first application for authorization. So they don't have to keep reapplying because the board will get subsequent arrest notifications. The third change is in that same section under subparagraph C on page 175.4. We have added in as a mandatory ground for denial of authorization to participate if the board has been unable to obtain a timely report of the results of the criminal history check. So to ensure that you have the information back before the authorization will be granted. On page 175.5, new subsection E, because this is the same sort of a notification, only it's going to apply to the individual. In the first situation, we have the sponsoring entity providing the notice to consumer, but because an out-of-state practitioner may also provide services at a healthcare sponsored by a local government entity, which does not register with the board, we wanted to make sure that the practitioner also provided that notice if the practitioner was participating in a sponsored health fair that was sponsored by a local government entity. So we've included the same language for the individual practitioner. The next change is on page 175.7, and this is the form 901B, and it is a conforming change to that goes along with the change to the payment of the cost for furnishing the fingerprints. We also added in language relating to the local government entity. On page 175.8, which is the second page of that form, we wanted to make sure we added in the valid and active license, because we would assume that you wanted someone to have a valid, current, and active license, not some other sort of status that did not allow them to practice in the state in which they were licensed. You'll see double underlined as the strikeouts on 175.9. That is simply, we weren't sure why this was included in the first place. It was from the form that was prepared by the department, and we decided that there was no reason to require it, so we were removing it. On page 175.10, we're adding in the name, the address of the local government entity or the nonprofit entity. So we have added in local government entity throughout, including on page 175.11. I believe the only changes to the next form were a change in the date, and to reflect that it's an MBC form, to distinguish it from other forms that the Department of Consumer Affairs might get, so that they understood that it was a medical board form. Are there any questions?
I have a question.
Yes.
Can I assume that this form and the information that it's going to contain would be used similarly by other health professions as far as providing services at the same kinds of events?
The first, yes, it should be a very similar form. What our office did was to try to create template forms for these regulations and for the forms. The boards need to modify some of the forms to suit their own needs and requirements. For instance, what you're requiring a physician to demonstrate by way of education and experience would be different than what the Board of Registered Nursing or some other, the optometry board might require. So the basic template is indeed the same, and we have given the changes to the Department for Dissemination as well.
Thank you. Are there any other questions from any other members? Can I have a motion to...
Okay, this would be a different motion if you have no other public comment.
Is there any public comment?
Okay, so the motion that I would seek and request that you make is a motion to authorize your executive director to adopt the modified language at the expiration of the 15-day comment period if there are no adverse comments.
Can I have...
So moved.
Do I have a second?
Second.
Okay, do I have any public comment on that motion or on anything from any of the board members? Okay, all those in favor, please say aye.
Aye.
Any opposed? Thank you very much.
Thank you.
So this closes the rule change opportunity. We'll move on to item number 6. Sorry. Dr. Mariana, you're on, please.
I'm going to give the report on the Advisory Committee on Physician Responsibility and the Supervision of Allied Healthcare Professionals. This is about our 4th or 5th meeting, and once again, we had a great overview of all the relevant rules and issues regarding the oversight of physicians with allied healthcare professionals. We felt that at the conclusion of this meeting that we've pretty much looked at every question we had that would inform us as to what is necessary and what we would like to be doing next. This time we had an overview of a current regulation 583, which is a notice to consumers add-on. We had a wonderful corporate practice of medicine overview with Mr. Lee, which was very enlightening as to the issues and the complexities of that part of the oversight. And we had reported the definition of a medical spa and the definition of availability, as well as a great overview from Ms. Scurry on the standardized procedures regulation from the BRN. We concluded that at the next meeting we'll have 2 action items, unless otherwise amended. First, we would identify the need for legislation that seems to be missing or lacking, perhaps even reattempting formerly failed legislative efforts. And also, we want to identify ways to educate both public and physicians as to the nature of these procedures and what the laws do dictate. And that is the conclusion of my report.
Thank you, Dr. Moran. Are there any questions from any of the members or from the public on that report?
Madam Chair?
Yes.
I want to thank Dr. Moran for her chairing this advisory committee. It's been a arduous task, and it's I think it's been very instructive and very enlightening on a variety of fronts. What I was wondering, if in fact this board, and this actually would have to be an agenda item for the next board meeting, if we could in fact perhaps communicate, this came up during the course of this committee, about communicating officially with the Board of Registered Nursing about many of the concerns that came up during the committee work or the advisory committee, so that it just isn't, you know, we talked about it and that's it. And I think that might be helpful, and I would think that would require an action item for the next agenda.
I think it's an excellent idea, and I would suggest that some kind of a compilation of all of the issues that were raised, some of the solutions or issues around whatever was raised, could be put into some kind of a documentation with our executive director assisting you, and then distributed that out to all interested parties, as well as our newsletter, as well as any other sources of opportunity for disseminating that information, because it really has been a wonderful opportunity to come together and try and have a discussion around specific items, and I really appreciate it, Dr. Moran. Thank you very much for your energy, efforts, insights. I'm going to ask Ms. Shipsky if she would mind if I could report out, unless you'd like to report out on the meeting that...
Well, since, Madam Chair, I was so busy in this other committee and you ably took over the Access to Care, I will defer to your report out.
Thank you. The Access to Care Committee had two presentations, actually. We're moving in the arena of collaborative care models and trying to inform the board as well as the public as to what are the different models that are out there and how can we best work within the system that is delivering care to many people that live in the state of California. So to that end, we had presentations by Dr. Eric Davidoff, who is the medical director of the Facey Medical Clinic. It's a medical clinic here in Southern California, I think, with 18 or three sites. In San Gabriel, San Fernando, one just opened in Simi, and another San something, I just don't remember, San something. So I apologize. It was very interesting. He gave a description and had slides as well as an explanation of the ability of them to work in a pod situation with nurse practitioners, with physician's assistants, and with other medical professionals. And it was, I thought, a very interesting presentation. The other presentation was from Dr. Paula Verdette, who is the medical director at Huntington Hospital, which is in Pasadena, where they are not only doing this kind of a model that you just heard about previously, but they have also actually people that actually deal with patients in the hospital and follow them through the process of going home and then following up to make sure that whatever needs that they might have to ensure they stay home and not come back to the hospital are in place, as well as maintaining two clinics on site, one at the hospital and one in an outlying underserved community. So I want to thank the chair of the committee, Ms. Shipsky, and as well as our presenters. I thought they were very informative. Thank you. So moving on to the licensing committee, item number 8. Dr. Salmonson, could you please make a presentation?
Licensing committee met yesterday. Mr. Warden.
Your microphone, please.
Mr. Warden was all things to all of us, having solo on this trip. I provided an update on where we stand with the applications. We know this is a busy time because the trainees need their licenses in June. And I did check the email from Kevin, who couldn't be here, chunky, for travel restrictions. 361 people needed their applications, their licenses by June. And there are just a few outliers that don't have them. 29 just applied in April, but they feel they'll still be able to get those done on time. 27 have yet to apply, and despite the matrix, so Mr. Shunke is going to be sending that list back to the training institutions to say, hey, we didn't receive a license application, so therefore we can't issue if we haven't seen the app. So I do think the combined effort of Mr. Warden, Mr. Shunke, the matrix, and the rest of the staff has put them on a timeline that's been really favorable this year. So I don't think anyone's training is going to be delayed as long as they brought in their own application. The other updates were regarding the business process reengineering project, which is ongoing. The policy and procedure manual had to be put on hold because of staff shortages, and the priority had to be put on getting the applications done. And Dr. Lowe and Mr. Worden provided an update on the international medical school approval process. And that really were the active items. That said, licensing committee is going to take a July vacation and not have a separate meeting at the board meeting unless other action items come up, and we took new agenda items for October. And that concludes our meeting.
Thank you. Are there any questions for Dr. Salmonson on this report? Any public comment? I have no slips. What I'm going to do now is, I said, oh, I apologize. I didn't have a slip. Wait. Come on up here. And then Ms. Thompson will get a slip from you in a few minutes.
Can I speak now?
Yes, please. Yes. Introduce yourself, because even though we know you're from Kaiser, not everyone else does.
I'm Hilma Balayan. I'm from the GME office, Kaiser Permanente, Los Angeles. I wanted to comment the efforts of the licensing committee, and in particular the outreach program, in improving dramatically during the last couple of years the licensing process of all the residents. I've been in this business for 12 years, and this is the first year that 2 months before the residence starts, we have the residents need license, second years at the end of June. This is the first year that we have all our residents licensed. This was unheard of. So I just wanted to comment on your efforts. Thank you.
Well, thank you for your comments, and we'll certainly relay them to the hard workers that have made that happen. And thank you to the graduate program directors as well. So thank you to you as well.
And also
I know it's been a collaborative effort with the Matrix.
And I also wanted to add that Kevin has been really a link between GME programs and the licensing committee and the medical board, because sometimes you are in situations that you're in dark, and he has been an invaluable link to clarify things, to make things work, to avoid pitfalls. Great. So I also wanted to specify that. Thank you.
Appreciate your comments.
Thank you very much. It's always nice to hear something positive instead of always something so negative. So thank you for staying, and thank you for those comments. I'm going to move to item number 12. It's going a little bit out of order, and ask Dr. Levine to please make a presentation on strategic planning.
Thank you, Madam Chairman. And this will be brief. The medical board is beginning its process of strategic planning. The prior strategic planning process was completed in 2008 and is available on the board's website for anyone who wants to look at it. Ms. Cordray, Janie Cordray, who is our consultant for research, has developed a board member survey, a staff survey, and questions for former board executive officers to begin creating a framework for the agenda for the strategic planning process. And board members will be surveyed between now and individually will be interviewed between now and the end of June, which will give Ms. Cordray enough time to process that information and to provide it to the board at our July meeting. And the plan at the moment is to convene a strategic planning meeting for the board the late afternoon prior to the the July board meeting in Sacramento. We will, and that will probably be around 3:30 in the afternoon on the 27th of July. And I'm just encourage the board members, the survey isn't to be filled out, it's just to prompt your thinking about what priorities we ought to be looking at in terms of a strategic plan and priority setting for the next several years. Thanks very much.
Make sure you read your email from me about the need to participate, please. It's really, really important if we want to have some kind of positive opportunity to participate in this process. I want to thank Dr. Levine for her leadership. Thank you very much. Now we're going to move on to item number 9 and ask Ms. Chang to please report out on the Special Program Committee update.
The committee...
I can't hear you.
Can't hear me?
No.
Now? The committee has recommended to the staff to approve the 2112 applicants after the staff do a site visit. So I think what I'm asking for the board is just to accept the report. So can you give a motion or something? Okay.
So is that in a second, please?
Second.
Okay, any public comment on this motion? Any comments from the board members? All those in favor, please say aye.
Aye.
Any opposed? Thank you very much, Ms. Chang.
Thank you.
We're going to move on to the enforcement report, please. Dr. Lowe?
Yes, the Enforcement Committee met this morning. We had an update on the probation practice monitors by Mr. Hepler. He presented an update regarding the issue of practice monitors and the difficulty that disciplined licensees may be having in obtaining such monitors. At the last Enforcement Committee meeting, there was concern that the licensed physicians may be reluctant to serve as practice monitors because of the fear of possible defamation lawsuits or tort action. Practice monitors, as you know, is a condition of probation and established by the Medical Board of California disciplinary guidelines. So their role is to review the charts, evaluate performance, and prepare reports for submission to the board. The board must approve the monitor as well as the monitoring plan. And so an analysis by the staff did not support the contention that the fear of legal exposure is a significant reason for non-participation. Other reasons were cited. Nevertheless, the probation program is revising the monitoring forms to recommend that a practice monitor seek and execute a, quote, hold harmless, end quote, agreement with the disciplined physician. The legal staff believes no further action is warranted on the issue of civil immunity and practice monitors. We then had a presentation on significant modifications and improvements that were developed to provide practice monitors with a formal structure to perform chart review and site inspections, along with a standardized report format to be used when preparing their quarterly reports to the board. These improvements will be put forth in place after the legal approval following this meeting. We also heard a presentation on how experts are utilized in both the complaint unit as well as the district offices. The B&P code 2220.08 requires that any complaint involving quality of care has to be reviewed by one or more medical experts with pertinent education, training, and expertise to evaluate the specific standard of care to determine if the case should be sent to the field or not. This requires a substantial utilization of experts, and so both presentations discussed the experts' qualifications and utilization figures. There's a database available that helps the investigators select the proper expert. They then interview the prospective expert to make sure that they do have the proper expertise. And then once the expert package of documents is prepared, it undergoes scrutiny by both the supervising investigator as well as the Deputy Attorney General to make sure that nothing is included that might bias the expert. So the current median time it takes for an expert package to be reviewed and finalized is 36 days, and our goal is to be under 30 days, so we're making progress. and it's ultimately the expert's opinion that determines the outcome of the case. Another presentation focused on process data markers, and this is for both the central complaint unit as well as the district offices. The data is relatively limited at the present time, but as we get more data, this should facilitate our ability to identify the areas of delay and make additional improvements so that we can be much more efficient. So the Enforcement Committee will not likely meet at the next meeting, but will reconvene in October. We will have some of the information reported in the enforcement report by Ms. Threadgill at that meeting. So that concludes my report.
Thank you. Is there any public comment on Dr. Lowe's report on enforcement? Tara Kittle, but you need to remember to fill out forms, okay?
Tara Kittle, I commend the Enforcement Committee for taking action to make things more efficient. But the one concern I have, given that there are so many medical cases that are very complicated, and as was even raised in the meeting itself, that physicians would approach things from different ways, it concerns me that it only takes one expert to determine that there was actually a breach in standard of care to move on to the next level. I would encourage the committee to consider a minimum of 2, just from different parts, maybe parts of the state, to provide more insight into whether or not there actually was a breach, or if this was just a variation of a way to approach a patient with an unusual case. Thanks.
Thank you. Any other public comment on this? Any other comments from the public, from the board? So we're going to move on to the executive committee report. My apologies. I'm going to report out on the meeting that the executive committee had, and that is that we conducted our evaluation, and that's the end of my report.
Okay.
That's under advisement, okay? Thank you. Any questions from the public on that? Anything from anyone else? No, thank you. Moving on to number 13. Dr. Lowe, could you please continue with the Physician Assistant Committee update?
Okay, the PA Committee created a Physician's Assistant Education and Training Subcommittee, which met on January 19, 2011. They discussed topics including the PA education and training, methods used by the PAC to approve PA training programs under current regulations. A significant proportion of the time was spent on the subcommittee's discussion on the fact that preceptors shall be licensed physicians engaged in the practice of medicine whose practice is sufficient to adequately expose preceptees to a full range of experience. Additionally, a preceptor shall not be assigned to supervise more than one preceptee at a time. So then at the following PAC meeting, direction was given to this subcommittee to go back and focus on the education aspect, and that the preceptor to preceptee ratio specifically should be reassessed, and they wanted a better definition of who exactly can be a preceptor. So the committee actually met on February 3rd, 2011. This was held at the UC Davis School of Medicine lecture hall. And some of the things that came up included just notification of everyone that the PAC, like all state agencies, is being confronted with numerous budget issues, and they're striving to make adjustments, including reduction of travel, enforcement, reimbursement, hiring freezes, and so forth. And so they're trying to do what they can to contribute to that effort. There are 2 regulations moving through the adoption process. One is the notice to consumers using language similar to what was adopted by the medical board. This file is being finalized for the DCA as well as the Office of Administrative Law. The other regulation will implement enhanced enforcement processes. Finally, the PAC has 3 legislative proposals that were submitted to the department. The proposals involve reporting requirements, the elimination of international graduate programs, and finally, the elimination of the provision in the law that allows a U.S. medical school graduate to take the PA exam. And the reason for this is that the National Examining Agency only allows graduates of approved PA schools to take that exam. So that concludes my report.
Thank you. Do I have any public comment on this report? Do you have any comments or questions from members of the board? Seeing none, thank you very much, Dr. Lowe, for your report. I'm going to now move on the agenda, and I'm going to give my President's report prior to number 14. I'm sorry. I want to take a few minutes to bring everyone up to speed on what I've been doing in my role as President of the Medical Board of California since our last meeting, the end of January. It seems that it drills down to conference calls, reading cases, attending meetings, being available, and being more than busy. Every month there's a DCA roundtable via the phone with all EDs, EOs, and their presidents or chairs. This includes the head of DCA, Brian Steger, and his staff support for issues that are raised during the 1-hour call. These issues range from general information to be shared as well as items on budget or staffing to the last one, which was on the continuing education and maintenance of licensure with 2 national participants. They're also an open forum with the opportunity to question, hear, and discuss areas of concerns that we may have, and know that I'm not a shrinking violet when it comes to issues that I feel need to be raised on behalf of our staff and our board. At the same time, I continue to have weekly conference calls with our executive director and her staff to review issues on a weekly basis as to what is being done to meet the public protection charge of this board, so that there is a weekly review of these statistics for licensing, as well as legislative issues and enforcement issues, as well as a status on the budget, staffing, hiring, freezing, and functionality or lack thereof. I have to tell you that I find constantly our staff eager and receptive to any questions and comments I have, and remind you that under the circumstances of a reduced staff with increased responsibilities and doing a lot more with a lot less, we should consider ourselves lucky and thankful for all of their efforts. The backlog on licenses are so far down from where we were 18 months ago, it's really like it was a bad nightmare. The outreach that Kevin Shunke has been doing with each and every teaching hospital in the state has made such a difference in their capacity, as well as the applications being presented in a more complete and a timelier manner. And we heard that verified today by the graduate medical advisor at Kaiser Los Angeles. Kurt Warden, our licensing chief, and his staff work well together, and they're stretched too thin, as is every section of the office. You'll hear more. You've heard about this already, and you'll hear more from our executive director, as well as to the status of the freeze waivers and the ability to hire from her report. But know that the medical board has its challenges. At the same time, legislation continues to take a priority in the public protection, and I want to thank Jennifer Simoes and our constant focus on making sure that our bills are being heard and that we're all engaged when appropriate and making those phone calls to support our bills with our legislators. I did meet with several legislators in Sacramento looking for sponsorship of our bills, as well as explaining the legislation, which has a purpose of educating them as to our role and responsibilities, regardless if they end up being a sponsor of our board-approved legislation. I sit as a member of the Midwifery Advisory Committee, and I'm pleased of the advancements they've made there as well. As a member of the Health Professions Educational Foundation, I have traveled to Sacramento as well as had numerous phone conversations with committee work and staff, and am pleased to report that there will be additional monies to be spent this cycle on the Stephen Thompson Physician Loan Repayment Program that we all know used to be a program administered by this board. This year there will be probably a doubling of the number of loan repayment opportunities. We've done some creative planning and collaboration with the state, and I look forward to sharing with you those exact numbers. But know they're multi-million-dollar opportunities this cycle. I want to thank our board member, Shelton Rousseau, for his help in setting up the beginning of conversations with Terry Leach, the interim executive director of the UC Center for Health Quality and Innovation, and Dr. Catherine Nation from the University of California Office of the President to discuss additional creative programs around the state that are happening, as to look to if there are needs to be additional legislation of monies available and appropriately used when possible. You all remember the presentation by Dr. Dowling from UCLA and his efforts to place doctors in community-based hospitals that have graduated from World Health Organization medical schools. and have now passed with the mentoring, help, and process the USMLE 1, Step 1, 2, and 3. I was fortunate to attend their graduation party as they begin practicing around the state of California. It was a very moving experience on probably one of the wettest days we've had here in Los Angeles, but one that I will always remember, that with an idea, regardless of the barriers, it can happen. And those 16 international graduates this year are making a difference to the communities that are lucky enough to have them. In April, I attended the statewide investigators conference and was able to meet with many of our very dedicated staff, who was able to finally come together for a statewide training program under the same roof. They were all motivated and excited to be able to participate, and I thank Renee Threadgill and her staff for making this, I'm sure, a very memorable and engaging learning experience. I've been invited to participate in statewide primary care work group, California Health Workforce Alliance. This work group has been meeting around the state, and I attended the one that I could here in Los Angeles. I have just returned from the Federation of State Medical Boards annual meeting in Seattle, and have to tell you that I did learn a lot. And at the same time know that we here in California, either because of our sheer numbers of licensees or our foresight or the insight and direction from our staff, have battled with issues that are now being dealt with by others. Many of the states do things differently, and that works for them. And I would look to further and future engagements as to where we can have a better, broader opportunity to share ideas and process with both boards that are similar in size or licensee size. But know that there are states out there with a similar size board and 1/10 the population of licensees. I want to be real clear that everyone heard that. We're doing a whole lot more with a whole lot less. And the only thing I can tell you that's constant, I think, is difference. I will tell you that with my own ears, I did hear from one executive director of one board that there are 3 public members on their board and that they would never be able to have a vote. I thought that was interesting. There were also boards out there that do the investigative work on cases. And then there are those that run the mediation on stipulations and decisions and have the public present for the discussion of outcomes, whatever they may be. Always there are terms which probably mean something different, but even in the arena where we use the term clear and convincing evidence, some use a different model, that being a preponderance of the evidence. It's different out there, but we are all charged with similar responsibilities. But all in all, I think it's very important that California be at that table and know that you have several board members here who are in place to participate. I sit on the bylaws committee and found actually a major takeaway for all of us in our daily lives. There is a free website there. It's called www.doodle.com. You can set up meetings with anyone you need to across any amount of space for free. Try it out. It's really made planning for meetings that take place in every time zone in this country easy, as long as you realize what time zone the meeting is being scheduled in, which sometimes is a challenge for me. Also, we've just learned that our own Dr. Sylvia Diego has been named to the PLAS Program Committee. PLAS stands for Post-Licensure Assessment System, and actually, as of Wednesday morning, her appointment was approved by both the FSMB and the MBME. So congratulations, Dr. Diego. Thank you. You deserve a round of applause. Staying with the Federation of State Medical Boards, I want to all let you know that our own Hetty Chang has been elected to a 3-year term of the Board of Directors of FSMB, a big honor and a vote of confidence with her ability. And thank you, Hetty. You deserve a hand. She ran a smart campaign, and her engagement in several areas on their board as well as ours proved well. Dr. Mary Lynn Moran continues on the nominating committee of the FSMB, and I want to thank her for her work there. She came through with a great slate of candidates for us to choose from. Dr. Salmonson, I want to remind everyone, did attend a USMLE committee meeting in Philadelphia at no expense to this board, I might add, or the state of California. And they will be developing questions as we go forward to for our licensees when they take their tests. Also, I would like to announce at this time Dr. Hayes Batista is going to join our Cultural and Linguistic Competency Committee, so congratulations to Dr. Hayes Batista, and we look forward to his engagement as well. Dr. Aguilar Axiola is going to also be attending, being engaged in the committee for cultural linguistic competency. Moving along with my report, I think you've heard enough. It's been an engaging quarter, one filled with continued progress in ensuring that the mission of the Medical Board of California, in fact, is being overseen. And I can tell you again, I can't tell you how much I really feel that I'm so fortunate to be able to be in this position and be engaged with all of us working together as a team on this board. And I thank you all very much for your attention. And with that, I'll move to Ms. Hetty Chang for her report. Thank you.
Thank you. With the last conference, there's quite a bit of issues, but strangely enough, there's some of them is just collide with ours. You know, we have an access committee. They emphasize on workforce issue. There will be a shortage of physicians, and it's being looked at the federation level, and I think it's being addressed in our level too. And we had, in the conference, we also have the physician health section, and which is like our wellness report, and which is similar to what we're doing. The Federation has done a huge telemedicine conferences, and that was just to put everybody in the nation in a place to gather all the information and to address issue, to identify the shortcoming, and where can we all start on a uniform basis. There's some new issue that were not addressed. One of them is like the reentry issue. Is when a physician has been out for a while, what is the current scope of what they're doing? And also they have this thing called maintenance of licensure. There's some state board is willing to take it up and be a pilot project. So the NBME and the Federation are working together and trying to see what can be done for that. One of the things that I do with the foundation of the State Medical Board, Federation of State Medical Board, is there is a new measurement project. I call it measurement. It's a sort of like a metrics project. What they're trying to do is, in lieu of there is no good measurement for a state board. I would call it not good measurement. I call it a comprehensive and really looking at what a state medical board is like, or what is a good state medical board. And this year, the new Federation chair, Jane Ryan, and the AIMS, which is the administrators in medicine, which is all the Lindas in the whole United States. They have an organization, it's called AIMS. AIMS and the Federation and the Foundation are together. We're looking at this issue. We will start from what they call a old tool called exchange, and which is to see the manpowers and what does each board do. And then that also includes the CAI, which is the similar factor that the public citizen has been using, and then also include all the other factors, and which will be, hopefully will be a very comprehensive result tool. It's like a toolbox for all the state board to use. So it's an exciting endeavor, and I'm hoping for great success. I have to compliment on our board participation in this, because I think it's a great honor we have someone like Janet to be sitting on USMLE, the exam portion, and have Dr. Diego sitting on the PLAS, which is the post-licensure measuring issues. And it shows that, you know, we're really doing good. And of course, our chair. Yeah. Thank you for your vote. Thanks.
It's my pleasure. Okay, any questions? I neglected to mention, and I apologize, Dr. Dussault we sit together on the selection committee for the Stephen Thompson loan repayment program, and I want to thank you very much for your participation and your insights there as well. Thank you.
You're welcome.
So moving on the agenda to the executive director's report. Oh, excuse me, I'm sorry. Board member communications with interested parties. I talk to everybody that's interesting, so I'm right there. But if anyone would like to, there's no conflict of interest with anyone I talk to either. Is there any board member communications with interested parties that they would like to discuss? I mean, I do talk to a lot of people. I don't know who's interesting, who's not. They all think they're interesting. But is there anyone here that wants to put out any kind of disclaimer? There's no conflict of interest with anyone I'm talking to, is what I'm saying. Anybody else? Conflicts? Okay, thank you. We're moving on to Ms. Whitney. Would you please present your executive director's report? Turn to, it's number 19 in your binders, please, or your, I don't know what page, 100 pages it is in your computers. 170.
If you'll please turn to page 176 of your agenda packet. This is the fund condition. As you can see in the column labeled Budget Act CY, that stands for current year, that's 2010-2011. The bottom line shows a reserve of $26.7 million. If we expend all of our appropriation, that will be what we would have, and it would be a 5.7 month reserve. The fund condition for the budget year, which is 2011-2012, drops to 2.9 months of reserve. This is due mainly to another general fund loan of $9 million, listed in the middle of that column. And you can see it in parens, and it says general fund loan. Can everyone see that? In addition, this fund condition still shows $577,000 for Operation Safe Medicine. That is not likely to happen this year. We're extremely disappointed with this outcome and are preparing to submit this augmentation request for the 2012-13 fiscal year. Hopefully, this new administration will understand the need to continue this program on a permanent basis. Are there any questions regarding the fund condition?
So let me ask a question that I know that most of the board members want to hear the answer to. The Office of Safe Medicine, which is the entity that goes out and takes a look at the unlicensed practice of medicine, there is no way that this can happen until next year? A renegotiation.
I have been speaking with the Deputy Director over Administration related to shifting some positions to cover the positions of those that are in the Operation Safe Medicine, but there won't be the same type of authority. Budget change proposal gives you clear authority. The pilot program authority does end. And so we can shift some positions to cover some of that workload, and we're working with the administration to do that, but it's not quite the same authority. Our authority in law says what our priorities are, and by budget change proposal, you can add different authority by different programs, and we had hoped to have this extended. So we are seeking a permanent establishment of this operation in the 12-13 fiscal year. Moving, I'm sorry.
Linda, before you move on, sorry about that. I wanted to bring to perhaps the public's attention, which is I think important to realize and understand a little bit more on the general fund loan issue. I believe the previous administration borrowed about $6 million.
Correct.
Were those funds returned?
No, they have not been returned at this point in time.
Okay. The $9 million that is being borrowed by this administration, when do we expect these funds to go?
There's no date on that, and I have that material in your binder that we'll get to in a couple minutes.
Now, I've looked at the conditions of the loan, and I think it's also fair for the public to realize it appears as though there is no specific date or a condition that is put there with respect to the return of the funds. In other words, it's almost completely discretionary, at least the way I see it, whether or not those funds would ever be returned.
Well, we might as well move to that then. If you'll go to page 186, this is the language that exists in the budget bill, and it basically says, the Director of Finance may transfer up to $9 million as a loan to the general fund. The Director of Finance shall order the repayment of all or a portion of this loan if he or she determines that either of the following circumstances exist. The fund or account from which the loan was made has a need for the money, and B, there are no longer a need for the monies in the fund or the account that received the loan. This loan shall be repaid with interest calculated at the rate earned by the pooled money investment account at the time of the transfer. So in essence, we would need to go back to the legislature to let them know that we are in need of those monies to have them returned to the fund.
Thank you.
If you'll turn to page 177, this lists the expenditures of the board through the end of February. This shows that we've expended about 62% of our authorization and 67% of the years completed. Projecting this out, we will underspend our authorization by approximately $1 million, largely due to furloughs and the hiring freeze, making it difficult to fill positions. On pages 178 through 181, the expenditures are shown by component. The remaining pages provide information on the probation monitoring receipts and board member expenses. On pages 185 and 186 are the pages from the budget, one of which I referred to earlier. 185 shows the $55 million appropriated to this board for next fiscal year, and then page 186 shows the $9 million borrowed. Are there any questions?
I have a speaker's slip from Dr. Paul Finney. Please, would you come forward? Speaking on number 19. Thank you.
Thank you very much. Paul Finney, practicing general pediatrician in the Sacramento area and chair of the Board of Trustees of the California Medical Association, CMA, with a couple of comments and a question. CMA is aware of the proposed $9 million loan and the existing $6 million loan, which to date has not been repaid, and is aware of the fact that there is no language in the statute as to a date it should be repaid. We are concerned, CMA, with this misuse of physician fees, and in that vein sued the state back in 2008 to invalidate the loan. The courts have not been sympathetic with that suit so far, but CMA remains committed to challenging the state's raids of physician fees. We believe, in essence, that balancing the state's budget with this kind of tactic is actually a violation or comprises a violation of the Medical Practice Act. So the focus of the courts in evaluating the legality of borrowing from the contingent fund has been whether such borrowing hinders the performance of the medical board's regulatory function. And as I look around, I sense that there is reason to be concerned about this. I think you probably all saw the LA Times editorial a couple of days ago, rather biting and hyperbolic, but calling the medical board a failed regulator and relating this failure to being, what they say, woefully understaffed and regularly robbed of budget funds. Even the agenda today on the front sheet says contains a disclaimer about it may not be possible to webcast the entire open meeting due to limitations on resources. And you heard from our president that that we have a staff that is doing a lot of work stretched very, very thin. So with all of this in mind, my question is, how will the proposed $9 million loan, especially combined with the $6 million already taken, affect the medical board's operation and its ability to carry out its very important regulatory function, both now and more importantly, going into the future?
I don't have any answers for you.
Well, a couple things. The Department of Finance does in fact look at our fund condition, and they look at it in the long term to make decisions on budget change proposals or augmentations. So our augmentation for the office, our Operation Safe Medicine, may be more difficult than we had anticipated with this type of loan out of our budget, but we hope not. As you can see in our budget, we've projected that money being paid out of our budget. So it still looks as though we have plenty of money to move forward and not suffer in terms of the fiscal resources that are available to the board, but that doesn't address the other executive orders that are placed on us in terms of resources of individuals or their ability to perform their duties in attending meetings or conferences or things of that nature.
Thank you.
I just wanted to add as a point of personal privilege on my behalf is that I feel that it's not only the issue of the loan money and that being repaid, but the ability to spend the money that we have that's available and the restrictions and constraints by process on that if that would be eased up over here, we could come a little bit up. So we'll hear from that entity in a little while too. They'll get the same question.
Very good. Thank you.
Well, it's basically saying the same thing, that I think it's a catch-22. We're forbidden to spend the money in the account. Therefore, it looks like we have a surplus while positions go unfilled. And therefore, because of the perceived surplus, it justifies moving more money out of our fund. And so I just don't see how to break that vicious cycle.
Ms. Shipsky?
I just wanted to add a point of clarification. That was not an editorial in the LA Times. That the article you referred to, that actually was an article by
a news article.
Reporter, not an editorial. The other thing is that Mr. Zerunian and I could possibly, I don't know if you guys got hit by this, but the state came to the city of Long Beach and took $6 million of our redevelopment. Oh, Frank, you don't have redevelopment in your area. They took $6 million with the promise that they might give it back, and now they are actually trying to fashion legislation that would take all of the redevelopment money and not give it back. So we're all getting in line to try to get money back that was taken on a loan basis. So we're all kind of in the same situation in government.
You've heard the old expression, use it or lose it. Moving on the agenda. Oh, you're not finished, sorry.
A new executive order was issued April 26 that places restrictions on travel. This too will impact the budget, reducing expenditures. The executive order allows for only mission-critical travel, such as enforcement and functions required by statute. Only a minimum number of employees are allowed to travel for mission-critical trips. As an example, our normal reduced staff to attend and effectively run a board meeting is 20. The State and Consumer Services Agency, our oversight agency, reduced this number to 12. This has had significant impact on staff and our ability to provide adequate coverage on all items of your agenda, and I apologize for this. This executive order impacts other work of the board. Our public outreach will be limited to where staff can drive via state vehicle and not require lodging or meals. This means that any public outreach in Southern California will be extremely limited and only provided by field office staff. This order applies to conferences, including those we have been invited to provide a presentation at. We will no longer participate. I will be seeking direction on our licensing outreach as we consider this mission critical. We may need to reduce staff in this effort, and I will keep you informed. as it relates to board meetings. This will not impact us in July, as our meeting is scheduled in Sacramento. But if this order is still in effect in October, and I am assuming that it will still be in place, then I would like your permission by motion to move that meeting to Sacramento.
I think you're a little...
Are we going?
Which meeting is that?
Where's it scheduled at? That would be the San Diego meeting.
Right.
So do you want a motion, or is it
That's
appropriate?
what I'm asking for.
If
Yeah,
you
I
want
move
a
that we
motion-
move that meeting to Sacramento. But
Pardon me?
I
didn't hear what you had to say. Dr. Lowe, would you repeat your comment, please? I'm surely interested.
I said I'd move that we change the venue of the meeting to Sacramento, but I must declare that I do have a conflict.
Thank you for that. I would suggest that a motion is appropriate to move it contingent on the fact that we find out. Yeah, we'll take public comment on everything when I finish talking. So we have a motion, we have a second on a contingency basis, if this is what is required, to move the San Diego meeting to Sacramento.
3 months.
3 months in advance. We need to know that, okay? So now we're going to have Ms. Shipsky.
I actually would oppose that, and I think the board needs to be very adamant with the administration. The purpose of moving these board meetings in different places in the state of California is to give access to the public as well as to the physician community who can't or don't have the means to travel. And, you know, I know our seat of state government is in Sacramento, but I would like to see the board go on record, you know, going back to the administration and saying this is not really in the best interest of consumers to be limiting where you're going to have your public board meetings. And I understand that there's technology and you can do video live streaming, but it does deny a certain aspect of the population the access to come to a public meeting. And I just don't want us rolling over and going, okay, you know, you've made this mandate about the budget. I personally feel very strongly about, you know, an agency that is funded by non-general funds, but it's funded by licensing fees, should not be put in the same classification as state agencies that come out of the general fund. We have a role and a mission, and we are supposed to be out there accessible to the public, and I would hope that we not just say, okay, and that we actually give a response back to the administration requesting, or actually just indicating that the meetings need to be placed on a quarterly basis in different locations.
Well, I want to thank you for that, because you saw my discomfort in requesting a motion to start with. So I would echo and support what you have to say, that the object of these meetings to move around the state is not so that we take 12 or 15 or 20 staff members out of Sacramento and put them in some other location around the state, but it's for the opportunity for the public, as Ms. Shipsky has suggested, as well as our professionals, as well as our elected officials in those areas, as well as our local medias in those areas, to have an opportunity to come forward to participate in the process of what we do. So to that...
And actually, Madam Chair, and also the minority of board members who happen to be in Southern California, the predominance of the board happens to be Northern California based. And so, you know, I think it's just really important that we stress that the meetings need to be rotated, and that
never thought of that. Thank you for
that. We need to get that exemption from the freezing in terms of the order about travel and things, and obviously being very judicious, as the medical board has always been, indicate that this is part of our mission and part of our, you know, that we're directed to do.
Thank you. Do I have some more public comment? Some comment first from the board members before I take public comment? Dr. Salmonson?
Well, it's a dilemma, because I so agree with all of your comments. Unfortunately, since we sort of limped through this meeting, I'm afraid that if we just hold their feet to the fire, we'll not be bringing staff, and that's a burden on the few staff that get to come. I don't know. I mean, I can see it both ways. I don't know what the better message is.
Well, this is only if we can't get a waiver, right? I mean, if we can't get a waiver and we can't have the full staff at that...
Then you're forced to.
then I think it makes a lot more sense. We'd have a better meeting with more staff. I mean, I can fly here. It's no big deal to me, but I just think that it's important to have a quality meeting, and the only way to have a good quality meeting is to have complete staff.
Okay, let's hear from some members. Oh, sorry. I'm going to hear from board members, but come on up, Tara. It's fine.
Just one more comment on it. I don't, if we intend to request a waiver, I think it should be more than a letter to the administration. It has to be a delegation, I think, of this board to impress upon the agency the significance of this. And we can't, put this burden on the staff to try and accomplish. We're going to have to get behind this if this is where we're headed, because the administration will have to tell the board no rather than the staff no. It's harder to tell the board no than the staff. So if we're going to go forward with this, I suggest that we put together a small dedication of the leadership of this board to impress upon them the importance and significance of why we have to do what we have to do.
Okay, thank you. Let's hear some public comment, and we can move forward. Tara Kittle, please remember your 3 minutes, please.
Thank you. I just wanted to echo, I absolutely agree. Like, you cannot have a quality meeting by denying access to the people of California. That is the whole point of moving around to different parts. It gives access to groups, it gives access to patients, to people who are sick, who maybe don't have the health to travel to Northern California, as well as to different various groups that maybe don't have the funding because of budget cuts to travel. So that meeting, they're one chance a year to bring issues to you, to the board for discussion. And I think, the state, as far as I'm concerned, is basically stealing money from the Board of California. It's time to step up and say, no, we need this money. This is what we're going to use it for. We are separate from you all in this regard so that you can keep the meetings open and fair for everyone. Thank you.
Thank you very much for your comments. Michelle Montersat Ramos, please.
Hello, my name is Michelle Montserrat Ramos. I'm from Consumers Union California Safe Patient Campaign. In November 2010 board meeting, I brought up the outreach component about including a telecommunication response or method to communicating with your consumers. It seems it's even more pertinent now, considering your travel restrictions and your restriction of staff to attend meetings. So if you would consider a teleconference component to your meetings where your staff can participate from Sacramento and consumers can participate as well, I think it would serve everyone's needs, including the board's.
Thank you very much. Paul Finney? Dr. Paul Finney, sorry.
Either way is fine. Thank you. This is this bears to the issue under discussion, but was generated by response to Ms. Shipsky's comments about the loans and the fact that the city of Long Beach or whomever is having their funds rated, and I heard from someone with the Board of Registered Nursing, their funds are being rated as well, and that it's happening as a tactic in many, many ways. CMA is specifically concerned about this from the standpoint of the Medical Practice Act, and I wanted to get this read into the record because I think it's an important distinction and does place the funds that we're talking about here in a different category. The Medical Practice Act statute specifically states that the funds are to be used solely for carrying out the activities of the medical board. The word solely is actually in the statute. It has additional specific language prohibiting transfer of medical board funds to the state. The way the courts got around this was to stipulate that, well, because this is temporary, doesn't really constitute a transfer. And CMA disagrees with that interpretation, as it's committed, as I said before, to continue that fight. In particular, having the $9 million added onto the $6 million, our feeling is that it would cause a definite difficulty with the medical board in being successful at carrying out its function. So that's the distinction I wanted to make. It's different than some of the other fund raids.
It is definitely different. You might want to consider having a change of venue or whatever the official term is and find a judge outside of California to hear your case.
Wow. Madam Chair, not to belabor it, but redevelopment funds are specific under redevelopment law to be used for blight, not for the governor's budget. So we're under the same kind of problem here, that money's being taken out of categories that are specifically designated by law for specific uses, and they're being pulled in and used for other purposes.
Okay, thank you.
Thanks.
Thank you. Dr. Lowe.
Ms. Curry would like to clarify my motion.
So the motion, as I understand it, is to move the October meeting to Sacramento if a waiver is not received within 3 months, at least 3 months before the meeting, as opposed to having the executive order still remain in place.
I apologize.
Could you say that again?
Could you say it again?
Kind of muffled.
The motion has a caveat if we don't have a waiver received within 3 months of the meeting. Meaning that today we're making it, the motion, the way it stands today, it doesn't say the meeting is moving. The meeting only moves, in fact, if 3 months prior to the moving, we don't have permission to move.
But we intend to do a waiver? Are we
Yeah, well,
intending to put in a waiver?
We would request, but right now we have public comment, so you can have comment after the public comment. How's that? Genevieve Claverall?
Good afternoon, Geneviève Claverol. You're getting better every time you say my name, so if I come enough...
It's the lisping with the tooth that's broken. Thanks.
Anyway, I'm very concerned when I see any idea of changing the location to Sacramento. We have the same problem with the Board of Nursing. Because of shortage of funds, most of the meetings are in Sacramento, so nobody goes. And I think the consumer has the right to have the opportunity to speak in different locations in California. I mean, you are a huge state, and I think it's totally unfair. And I hope you will not come to that decision.
Okay, thank you. Helma Balakian? I can't. I really butchered it. Inch Besses? Okay.
The record reflect that,
Let the record reflect that I only asked her in Armenian. How
Armenia's
is
pretty
she?
good.
I apologize. Yes, I've heard that.
Hilma Balayan, Kaiser Permanente GME office, Kaiser Permanente Los Angeles GME office. My comments might seem like preaching to the choir, but I still think that it is important to illustrate how the efforts of outreach program both saves money and also time to the medical board and to medical residents equally. Due to these concepts developed by the outreach program, now in our facility we are doing a yearly licensure fair, which makes it easier for the resident to go through different stages necessary for preparing their paperwork, which are notary public, taking pictures, and electronic fingerprinting. So we'll bring all these to the licensure fair, and also the outreach program representative, Kevin Chunky, or somebody else, we have had other people come here. So this notably saves time to our residents versus taking away time from their training to go different places and do all these steps. And also Kevin helps them what are the different steps, how you need to process with this. So that's really helpful and saves them time. And also our first years who are a year and a half away from needing the license, they start to apply for it a year and a half in advance, and this really makes it easier for the board to process this versus having all the requests that last 6 months right before the residents need license. So there is tremendous time saving there, and also Kevin goes over each single application, catches the errors, which avoids residents to send their application to the board, and then the reviewer noticing these errors and sending it back. And so again, it saves a lot of time. And it goes without saying that all this also reflects on amount of money saved, because reviewers will focus more on other issues versus dealing with these errors. and also to residents, because like instead of sending their diploma with a overnight mail and getting it back, they can just give a copy of their diploma to Kevin and he'll take it to the board. Of course, he will witness the diploma. I'm going in detail because I think devil is in details, and all these things are done by the outreach program and Kevin Chunky, and because of restriction in travel time, taking this away from residency programs will be really a tremendous error.
Thank you very much for your comments. We're going to move on the agenda now, but before we do, we're going to have a vote on the motion unless there's some more comment from the... oh, I have to comment. Thank you, sir.
Madam President, it's with great reluctance that I speak because things rarely get better when an attorney talks. But it's my
They're more costly, for sure.
Yeah. It's my
Speak for yourself, by the way.
Okay, I am. It's my understanding that really what we're contemplating here is that if the executive order restricting travel is in place and the medical board cannot get the necessary travel exemption or travel waivers for the sufficient number of staff to attend the out of Sacramento meeting, then the meeting will be moved to Sacramento. Is that sort of the...
Exactly clear. Thank you. Even I got that, and I'm not a lawyer. Okay, any more comments from members of the board on this motion specifically, or from anyone else in the public arena? All those in favor of the motion as stated, please say aye.
Aye.
Those opposed?
Opposed.
And I'm going to abstain. I understand what's going on, but I have a problem with it. Thank you.
Just for point of reference, the meeting in July that we will have in Sacramento had been planned to be at the UC Davis School of Medicine, but the session starts for the students and they didn't want to move out of the conference room, so we do not have space there for us this year, but we will schedule there another year. Moving on to the next item regarding positions, vacancies, etc. As of May 1st, the board had 45 vacancies. This does not include the 16 CPEI positions that were authorized this year. There are 5 more known retirements for May, although it appears that we might be able to fill a couple of positions from within DCA. We have submitted 4 freeze waivers for positions in the medical board. And the process is, first we submit it to the Department of Consumer Affairs Fiscal Office. That moves then to the director. It goes to the State and Consumer Services Agency. It moves then from there over to the Department of Finance, and then it goes to the governor's office for approval. The first one was the medical consultant licensing for 8 permanent intermittent positions. It was submitted as a freeze request before the executive order on 2/14, but resubmitted on March 14th under the new process and approved by the governor's office on April 20th. The medical consultant enforcement for 8 permanent intermittent positions was submitted March 21st, and it has finally moved to Department of Finance, and that was as of notification on Wednesday. The Supervisor 1 enforcement positions for our field offices, we have submitted for 5. That was submitted on April 5th. It is currently at DCA Director's Office. The office technician positions, that's for cashiering, that's income generating. Our phone or call center where we take all of our complaints and all of it's the first entry of anybody calling into the medical board. And our front end support for licensing, that's putting the files together so they can go to an analyst for review. We requested 6 positions. It was submitted April 20th, and it is still at DCA Fiscal. Next week we hope to have the investigator request sent to DCA. I want to review quickly our vacancies so you can understand where the 45 vacancies exist. In the executive office, we have 4 vacancies just in the executive structure. In administrative services, we have 2 vacancies. Business services, we have 1. Licensing, we have 12.8. In our CCU, or upfront complaint section, we have 4 vacancies. Office of Standards and Training, 1. In the enforcement program, excluding the probation section, we have 14, and when you add the probation, which is 6 vacancies, you have 20 for the field programs. And again, that doesn't include the 16.4 vacancies that we have related to the CPEI. One of the most critical losses will be the retirement of Debbie Titus in mid-June. Debbie has been the board's budget analyst since 1986. You can't easily replace that kind of expertise. We're in the process of interviewing, but this board will suffer a huge loss with this retirement. You can't train somebody to get up to speed in a short period of time with the knowledge base that Debbie will be taking away. We will be examining the opportunity of a freeze request for a retired annuitant to have her come back if she were willing to consider that. But again, freeze requests take about a month and a half to 2 months to get through. In March, the acting director issued a policy statement prohibiting board members from serving as expert consultants in the licensure examination development process. Since we have physician members who serve as invited guests by the Federation of State Medical Boards on the Exam Development Committee for the USMLE, I asked for clarification by the department. It was clarified that national examination development workshops are not included in the scope of this new policy. So we are not included in that policy. So Dr. Salomonson will be able to continue the process that she's working on. Thank you. I would like to report that Jennifer Samos, as our acting public information officer, has been very busy in this second job in responding to various press requests. We're still trying to fill that position, but have had very limited group of applicants interested because they have to come from within the Department of Consumer Affairs. This is the only source of applicants without a freeze waiver. Lastly, I would like to commend all of the staff at our headquarters office and all the staff that have attended this meeting today. Everyone has stepped up when we were significantly cut in numbers, especially those who had to attend this board meeting and get information from those who could not attend, and learn those presentations or to track the meetings of those individuals who were the managers of the committee meetings. We wanted to ensure that those of you were taken care of here at the board meeting and that the appropriate information was provided to you, even though we were assuming roles of someone else and we didn't have as much knowledge about the materials as the original staffer. I want to thank the field enforcement staff for attending each of our board meetings to ensure security here. It's very important to us, and thank you for being here with us today. And we had 2 individuals here yesterday. And that concludes my report.
Do I have questions of the executive director for her report? Any public comments on? No, not on hers. No. So I have no public comments. Oh, I do. Tara Kittle.
Tara Kittle, just a couple of really quick points. One thing in regards to getting around this new restriction on travel is to maybe look to hire locally for certain things, like setting up the sound system and things like that, or security, to maybe work with the hotel. I'm sure they have contacts. The other thing is just a reminder of that idea of setting up some kind of subcommittee to work with going back to the legislature to get a waiver. Because my only concern with that motion that got passed is it sounded like to me that it's basically going to happen because it's too complacent. So if the board doesn't take active leadership, I have a feeling the staff is just going to let it not happen. So I just encourage you to do that. Thank you.
Thank you for that. Any other, Ms. Chang?
I just have a thought. You know, after hearing Linda's report, it almost seems like, maybe you guys can tell me how you think, is we're reaching some point of almost crisis or to that level. So is it possible maybe the chairman of the board maybe discussing with Linda, and then we come up with some kind of a plan and to discuss how we address this issue?
I think it's an excellent idea. I think the issue of some kind of strategic planning would be great. If I could understand, as I'm sure if our executive director could understand best why people are leaving their job, if it's the stress, if it's the salary lack thereof, if it's the engagement, and I will be querying her on that. But I think that we need to also expect from our agency and the department a faster turnaround time. I probably 2 months ago went to our executive director and said, I'm not happy. I want to hear a freeze request every single week. I want to hear a report back that every single week you're checking on them, and I don't care that you're being bugged or you're bugging them. The train is leaving the station. Either we're all going to be on it together or we're not. So to that end, be assured, Ms. Chang, I thank you for your admonition on this. I'm not going to be letting up on our executive director, and she knows that. She doesn't have it so easy. For all of you that think out there that it's, she's got a great job. She probably does have a great job, but she has lousy. She doesn't have it easy. Let's put it that way. She has to. She's called to task at every opportunity.
No, what I'm trying to say is helping her with.
And just so you know, the individuals that I mentioned would be leaving in May. Those are retirements. We have one retirement in June. We have two that we know about for July and one for August. So those are all retirements. They're not leaving because they're unhappy with state service or the medical board. We are hitting a point where we've had employees with us for a long time, and you have the baby boomer retirement, and that's the real world in state government right now. So these at least are planned retirements. They're not surprise retirements, and some people may choose to do that too. We hope no one wins the lottery at the office because we might lose them, although we hope they win it so they have the opportunity.
Maybe the retirement age should mirror the Medicare opportunity age that's is being talked about now in government, and maybe that has to be raised. So, let's move on the agenda. I know you don't want to hear from me anymore. Now we're going to go to. You're getting younger every minute, so don't worry about it. We're going to go to legislation. Ms. Simoes, could you come up, please? Oh, you're here. Thank you. Everyone could take out their legislation binder. I would appreciate it, and let's move on this.
Okay, good afternoon. And there's also some handouts that you should have received, and they're a blue cover. There's some updated analyses, and there's an updated tracker sheet with the pink highlights. And this is just because things are moving through the legislature, so the statuses are changing and things are getting amended. So let's move to the tracker sheet with the bills highlighted in pink. The sponsored bills are in pink, and we'll be going over most of these bills as this is the first time the board has seen them. So we're going to go ahead and start with the bills in pink, which are the board-sponsored bills. The first bill is AB 1127 Brownlee. This is the bill that would make it a violation of unprofessional conduct for a physician and surgeon who is the subject of an investigation by the medical board to fail, absent good cause, to attend and participate in an interview scheduled by mutual agreement of the physician and the board. The board decided to sponsor this bill because it believes it will help to expedite the closure of disciplinary cases and significantly reduce case delays by providing an incentive for physicians to attend and participate in physician interviews. This bill was recently amended to address concerns raised by the California Medical Association, and they are now neutral on this bill. And this bill recently passed out of Assembly Appropriations Committee on Wednesday. Does anyone have any questions on this bill?
No, please continue.
No?
Okay, I need, come on, you guys, I need public information slips. Let me ask you a question. Do you want to go through all of them, or you want to go through this one specifically? You want to, I'm asking you seriously. Would you rather, you want to do this one specifically, or you want to wait till all the legislation is done?
Yeah, let me just say.
Okay, fine. I was only asking.
Yeah.
The microphone, identify yourself, and don't forget to slip,
yes,
please.
Rehan Sheikh. Has someone got an opinion from a legal counsel or from an attorney general? Will this bill violate Fifth Amendment right of physicians?
Remember, wait, stop. Remember, this is an opportunity for you to speak for 3 minutes. This is not a question answer. This is not a dialogue. This is not a... If you want to talk to Ms. Simoes when you're done, you're welcome to, or anyone else here, but this is only your opportunity to inform us of what you want to tell us.
Yeah, could someone please let public know that if this bill violates Fifth Amendment right of physicians sometime whenever you get a chance? Thank you.
Thank you. Interesting. Okay. Continue, Ms. Simoes, please.
All right, the next sponsor bill is AB 1267 Halderman. This is the bill that would authorize the board to automatically place a physician's license. Previously, it was on automatic suspension order. We've recently amended the bill after meeting with CMA to change that to an active status. This achieves the same goal. The physician would still not be allowed to practice medicine while incarcerated. This would be an internal action that would change the license status to inactive, and it would still require disclosure on the board's website for the public, and the fact that the physician is incarcerated would be disclosed. Although on your analysis it states that CMA is opposed, that has changed. They are now neutral on this bill, and this bill is passed out of both Assembly BMP and Assembly Appropriations on consent, which basically means it has bipartisan support and no opposition. Does anyone have any questions on this bill?
Questions? Okay, continue.
Okay. Our last sponsor bill is SB 541 Price. This board is co-sponsoring this bill along with the Contractor State Licensing Board. The board voted to sponsor our own bill if not introduced. So this is a bill that would enable all boards and bureaus in the Department of Consumer Affairs to continue to utilize expert consultants in the same manner has been done in the past without going through the formal contracting process. If this bill passes, all boards would be allowed to complete a simplified contract, which would mean 2 pages instead of 20 pages, and an expedited process, including allowing a delegation to the boards for the contracting authority. This bill passed out of Senate BMP on Monday with no votes, and many of the boards support this bill. Anyone have any questions?
Any questions?
At the last meeting, the board voted to sponsor a bill that would just apply to the medical board. Since the board voted to sponsor that, we went forward with co-sponsoring, but there may be a motion needed to reaffirm that position of sponsor support.
So we need a motion to confirm sponsor support of SB 541, current prices, regulatory boards, expert consultant. Do I have a motion, please?
So moved.
Second? Public comment on that motion? Comments from the board members? Seeing none, all those in favor, please say aye.
Aye.
Aye. Opposed? Abstentions? Okay, continue. Sorry, thank you.
Okay, thank you. Lastly, the board does have just a couple technical changes to be included in an omnibus bill. Committee staff is reviewing our language, and they'll be letting me know if they're going to be. It will be amended. If it is, it will be in the next house. So I don't have anything to show you today. Okay. The next item is potential new legislation tab in your, and Ms. Whitney will be presenting this item.
Thank you. If you will all recall, a few months ago we had a presentation by Dr. Dowling of the UCLA International Medical Graduate Program, and in his presentation he mentioned that the graduates in this program were not allowed to do clinical work. They had to do observerships because they're graduates of medical school and they're getting training so they can proceed into postgraduate training slots. He suggested changing a specific section of code to allow these individuals to train. Board staff was hesitant about doing this. Thus, we got into conversations with the UC President's office. That office has also been in contact with our board president. And in those conversations, they would like to examine the possibility of a pilot program that would enable these individuals to do a limited number of weeks in a clinical training type program. And so what I'm bringing to you today is I'm proposing that the board authorize staff to develop with the UC system language to allow for a pilot program at UCLA for up to 5 years for those individuals in the International Medical Graduate Program who meet specified requirements such as testing and language skills, etc., for them to engage in supervised clinical training of up to 10 to 20 weeks, and that if we can develop this and gain support from interested parties, that the board would co-sponsor with the UC system. And the reason I'm asking for this now is because if we can develop this and move it into the second house, that would happen before your next board meeting. So I would need your authority to move forward with that. It would, of course, come back to you in July, but again, the operative part is if we can gain support from interested parties, which means the other medical schools as well as all of the physician groups that might be interested in this.
Thank you, Ms. Whitney. Do I have a motion to move this forward?
So moved.
Second?
Second.
Any public comment on this? Any questions or comments from the board? All those in favor, please say aye.
Aye.
Any opposed? So be it. Thank you. Continue, please.
All right, now let's move on to the 2011 legislation tab. The first bill is AB 352-ing, which is co-sponsored by the American Society of Radiologic Technologists and the Radiology Practitioner Assistant Society. This concept was actually brought to the board in November. This bill would enact the Radiologist Assistant Practice Act and would require the board to create and appoint a Radiologist Assistant Advisory Council, which would be similar to the Midwifery Advisory Council, and it would consist of members of the public and qualified physician surgeons. The RAAC would make recommendations to the board on the establishment of standards and issuance of approval for programs, the scope of practice for radiologist assistants, using the guidance from existing things that are out there like the American Society of Radiologic Technologists, the American Registry of Radiologic Technologists, and the American College of Radiology, and the Certification Board for Radiology Practitioner Assistants. This bill would allow licensed RAs to perform medical services set forth by regulations of the board when the services are rendered under the supervision of a qualified physician and surgeon. The bill defines supervision to mean that the qualified physician and surgeon must be present on the premises and available to the RA when the medical services are rendered, and must oversee the activities of and be responsible for the medical services rendered by the radiologist assistant. This bill only allows physicians and surgeons to supervise up to two, I'm going to use the word RAs instead of saying it every time, RAs at any one time. This bill prohibits the RA from interpreting images, making diagnoses, or prescribing medications or therapies. Although the scope would need to be defined in regulations, the bill requires the scope to include obtaining patient consent prior to beginning an examination or procedure, and obtaining medical imaging necessary for diagnosis, and providing initial observations to the qualified physician and surgeon. The bill would require the RA and his or her qualified physician and surgeon to establish written guidelines for the adequate scope of the RA. This bill allows this requirement to be satisfied by adopting protocols for some or all of the tasks performed by the RA. The board would be required to issue licenses for RAs and recognize the approval of training programs for RAs approved by a national accrediting organization. With healthcare reform on the horizon, there's an increased need for physician extenders due to workforce shortages. This bill will allow RAs to be radiologist extenders and perform some functions currently being done by the radiologists that they are trained and educated to do. The supervision elements in this bill are modeled after physician assistants and require physician supervision and protocols to be followed. The RAAC is modeled after the Midwifery Advisory Council, which will result in minimal fiscal impact to the board. According to the author's office, RAs are licensed and regulated in 29 other states, and similar approaches have been successfully adopted in 5 other states. Staff is suggesting a support position on this bill, and I believe that there is a representative from the sponsor to come speak on this bill.
I have several speakers that I have slips on, so let me ask Bryce Daugherty to come forward, please. Again, 3 minutes, okay?
Be very brief. Madam Chair, members of the board, Bryce Docherty on behalf of the sponsors of the bill, the American Society of Radiologic Technologists. The only thing I'd like to say is we were here at the November board meeting to introduce this issue to everybody. I want to thank you for your time then and thank you for your time now. Secondly, I just want to thank Jennifer and her work on the analysis that was presented to the board. I think there are some consultants in some of the committees in the legislature that could take a lesson from the way that kind of played out. And thirdly, I just would like the board to know that this bill has already been amended 3 times, and it is only the first week in May. So we have been spending an enormous amount of time. There's been a constellation of amendments. We understand this as a big issue. It's a very important issue, and we've worked through any and all issues we've had with our physician colleagues. And I want to thank your legal team, Kurt, and others for the technical assistance that we've gotten to make sure that we streamline this process as quickly and as easily and as cost efficient as possible. And our intent has always been from the beginning to make this a wholly fee-supported program, and those licensure fees would be set by the board itself. So I just want to thank you for your time. I have 2 other just really brief witnesses, Sal Martino, who's the CEO of the American Society of Radiologic Technologists, and Dr. Kenneth Chin, who is a board-certified interventional radiologist practicing in Encino. Thank you.
Thank you very much. I'll call Sal Martino. Come forward, please.
Good afternoon. I'll be brief also. My name is Sal Martino. I'm the CEO of the American Society of Radiologic Technologists. ASRT is the National Professional Association that represents 140,000 medical imaging professionals throughout the country, of which radiologist assistants of RAs are our members. They are the mid-level physician extenders in radiology. I'm here today again to ask for your support in licensing RAs in California and ask California to join the 29 other states that have licensed RAs. ASRT has worked closely with the California Radiologist Society, other physician specialty organizations in California to refine this bill, and we've gained their support. The RA was created to assist radiologists by taking on some of their traditional responsibilities in performing imaging procedures and allowing radiologists to concentrate on interpreting medical images. The RA gains additional education and clinical experience which prepare them to take on these tasks. With the healthcare system poised to absorb many more patients as a result of healthcare reform and aging baby boomers, we believe RAs will help improve patient access to procedures and also reduce costs, since procedures performed by RAs will be reimbursed at a lesser rate than when performed by a radiologist. As I said, RAs have been licensed in 29 other states, and their utility and necessity has been validated by research in several of these states. My hope is that California will become the 30th state to license RAs, and therefore the graduates of Loma Linda University's RA program will be able to practice in California. Thank you very much for your consideration.
Thank you very much. Dr. Kenneth Chin, would you please come forward?
Thank you for the opportunity to speak to you, to the board. I'm a diagnostic and interventional radiologist in Encino, California. I have been past president of the California Radiological Society, and I'm currently volunteering my services as a member of the Board of Trustees of the National Certifying Organization for the Radiology Technologists and Radiologist Assistants, the ART, the American Registry of Radiologic Technologists. I want to thank the board for taking on the role of considering licensing and regulating and monitoring the activities of RAs. RAs will serve radiologists in the assessment and management of our patients. It's hoped that they will be able to assist in performing some of our procedures, both simple to complex, and in supervising our radiologic technologists, and ever increasing responsibility. We hope that licensure and regulation will allow us to provide radiologic care to an ever-increasing number of patients while assuring the highest level of concern over radiologic safety, a big issue that's currently a hot topic in the public eye. The board will also be able to monitor issues, assuring that RAs practice within the confines of their scope of service. I'll be glad to answer any questions if you have any. Thank you.
Any questions? Thank you very much for your presentation. Jennifer, continue, please. Oh, excuse me, Dr. Stan Formansky? He's not. Okay, thank you. Continue.
Okay, so on this bill, board staff is suggesting a support position, so there needs to be a motion.
Okay, I need a motion to move this forward. Can I have a motion to support, please?
So move.
We have a second?
Second.
Any public comment? Any comment from anyone on the board? All those in favor of the motion as it stands, please say aye.
Aye.
Any opposed? Any abstentions? So done. Thank you, Jennifer. Mrs. Moe, sorry.
The next bill is AB 374, and this is one that an update was provided. It has the blue cover that was provided to you today. AB 374 Hayashi. This bill is sponsored by the California Athletic Trainers Association. This bill would enact the Athletic Trainers Practice Act effective January 1st, 2013, and would establish the Athletic Trainer Licensing Committee within the Medical Board. The ATLC, which is the Athletic Trainer Licensing Committee, would consist of 7 members, 4 licensed athletic trainers, 1 public member, and 2 physicians and surgeons, licensed by the board or the Osteopathic Medical Board, or a doctor of chiropractic licensed by the State Board of Chiropractic Examiners. The bill was recently amended to add a grandfathering clause. This bill defines the practice of athletic training as the professional treatment of a patient for risk management and injury prevention, the clinical evaluation and assessment of a patient for an injury or illness or both, the immediate care and treatment of a patient for an injury or illness or both, and the rehabilitation and reconditioning of a patient injury or illness or both. The bill requires an athletic trainer to refer a patient to an appropriate licensed healthcare provider when the treatment or management of the injury, illness, or condition is not within the scope of the practice of an athletic trainer. The bill requires an athletic trainer to render treatment under the direction of a physician and surgeon who is required to order and oversee the athletic trainer and is responsible for the activities performed. The direction must be provided by verbal order when the directing physician and surgeon is present, and by written order when the physician and surgeon is not present. The bill authorizes the ATLC to adopt regulations to implement this bill and allows the committee to consult professional standards issued by the National Athletic Trainers Association, the Board of Certification, or any other nationally recognized professional association. The bill requires the ATLC to approve education and training programs for athletic trainers and states that protection of the public is the highest priority for the ATLC. According to the sponsor, athletic trainers are on site at professional, collegiate, and some high school games. An example of care provided is that an athletic trainer will treat an athlete who gets hurt during a soccer game by administering advanced first aid techniques and refer the athlete to the team doctor. There are approximately 2,500 potential athletic trainer licensees in California. The board believes that this bill will result in significant fiscal impact to the board. Implementing this totally separate committee would result in staff costs, workload, basically creating a whole new committee within the board. We use some assumptions, assuming 2,500 potential licensees with fees. It does not look like the actual fees will cover the costs to the board. Board staff is actually suggesting an opposed position on this bill. We really believe that the ATLC is not appropriate to reside within the board. We believe that it would be more appropriately placed in a board like the Physical Therapy Board or as a semi-independent board like the Physician Assistant Committee under the Department of Consumer Affairs. It also seems that the scope of practice for athletic trainers overlaps with that of physical therapists, and that would be more appropriately placed in the Physical Therapy Board. The bill proposes that athletic trainers operate under the direction of a physician and surgeon, but the term direction lacks definition in law. The more common term to use is under physician's supervision. With physician assistants and nurse practitioners, standardized procedures are developed when acting without the presence of a physician. Lastly, the scope of an athletic trainer in this bill is very broad, in that they are allowed to clinically evaluate and assess a patient for an injury or illness or both, immediately care and treat a patient for an injury or illness, and rehabilitate and recondition a patient. This seems to be very broad authority for the care and treatment of patients by an athletic trainer. Board staff is suggesting that the board oppose the bill in this form. We think that the board could be neutral if the scope of practice is more clearly defined, if supervision is more clearly defined, and if the ATLC is moved to another board or is an independent board.
Okay, so you've heard the recommendation from staff. Is there any public comment on this? So, wait. Yes? Sorry.
I would also note that the bill is missing grounds for denial similar and for discipline similar to what the medical board has, which would include criminal convictions or fingerprint check. Those are missing from the bill.
I have a question, Jennifer.
I have a question.
Is there a license in other states? Because this is certification for athletic trainers.
So now there's certification that exists, and in going to the hearing, just briefly, in going to the hearing on this, now a person can be in California a certified athletic trainer, but there's nothing against from anyone saying I'm an athletic trainer. Not using the word certification, there's basically no licensure. There was arguments made at the committee that, well, you already have certification, so you could be a certified athletic trainer. What's the need for licensing? There is licensure in other states, but there is not in California, although we have a certification process, which is a national process that's already out there, that people are already employed as athletic trainers. They feel that there's also a need for licensure.
Question, Mr. Zeronian?
How did it get to? How did this get here, or how did it get to us? I mean, it seems to me this is a. I mean, for ages we have had these folks providing services to colleges as well as professional athletes, and they're a captive audience. They're not just general consumers. I mean, presumably their organization wants to take care of their own people. I mean, what's the story here? I don't get it.
It's really what I was really saying to Dr. Israelian, that there's, on one side, a group feels that they're basically an unregulated kind of, anyone can call themselves an athletic trainer and they don't necessarily have to have the proper training because they're not certified. The general public doesn't know the difference between someone that says, I'm an athletic trainer or I'm a certified athletic trainer. Although there is a certification process, as you say, that there's people out there working that are certified nationally and that are going through the proper steps. And in this bill, we'd be, if the committee were to exist, we'd be allowed to use some of these national certifications. They believe the licensing element is necessary to only allow licensed individuals. So in that vein, no one could just go out, as they say that they are doing now, and say, I'm an athletic trainer and receive no training.
It increases the potential for the certifying body to gain new members.
I said it was money. So I have a request for a motion to oppose.
So moved.
Second. Any public comment? Any questions from the board? All those in favor of an opposed vote on this, please say aye.
Aye.
Any opposed? The opposed? No. Okay. Thank you. Mrs. Mose, continue.
Okay. The next bill was recently added, so you should have an update. It's AB 415 LOG. This bill is sponsored by the California State Rural Health Association. This bill repeals existing law related to telemedicine and replaces this law with the Telehealth Advancement Act of 2011. It repeals all of existing law and defines telehealth as the mode of delivering health care services and public health via information and communication technologies to facilitate the diagnosis, consultation, treatment, education, care management, and self-management of a patient's health care while the patient is at the originating site and the health care provider is at the distant site. This bill states that telehealth facilitates patient self-management and caregiver support for patients and includes interactions and some technical terms of how that how the interactions would be transferred. This bill states that this section shall not be construed to alter the scope of practice of any healthcare provider. This bill also applies the Business and Profession Code section to the laws relating to healthcare service plans and to the insurance code, and requires healthcare service plans and health insurance companies to adopt payment policies to compensate healthcare providers who provide covered healthcare services through telehealth. This bill also applies these requirements to the Medi-Cal Managed Care Program. According to the author's office, the purpose of this bill is to remove barriers in existing law and update the law to current practice regarding the use of telehealth in the delivery of health care. The author's office believes that telehealth has the potential to reduce costs, increase access, and improve quality of care, especially in underserved areas of the state where it is difficult for patients to get specialized care. Board staff suggests that amendments are needed in order for the board to support this bill. Existing law that this bill would repeal provides that a violation of telemedicine law constitutes unprofessional conduct. This language should be added back to this bill. This bill should also include the remainder of the language in existing law related to not altering the scope of practice of any healthcare provider. The portion related to delivery of services in existing law should be added. Board staff also believes that the bill should add language that would clarify that the physician is responsible for determining if the treatment is appropriate for telehealth. This should not be decided by the payment policies that are required to be adopted by healthcare service plans and health insurance companies. Board staff is suggesting a support if amended position on this bill. Some background, this bill was heard this week in Assembly Health. I talked to the consultant, and the first two of those amendments, I believe, were taken in committee. They're not out in print yet. That third amendment is something that we could work with the author's office and Assembly Health on. They agreed that the third amendment's needed.
Do I have a motion on the table, please, to support this? Okay, first and second?
Second.
Okay, do you have a public comment on this? Have any comment or questions from the board? So all those in favor, please say aye.
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 Any opposed? Thank you. Continue, but shorten it up.
Okay. AB 507 Hayashi is sponsored by the American Cancer Society. It would make changes to existing law related to severe chronic intractable pain, and would repeal existing law related to allowing the Department of Justice to employ physicians for interviewing and examining patients related to prescription, possession, and use of controlled substances. This bill would continue to allow physicians to refuse to prescribe opiate medication for patients who request a treatment for pain or a condition causing pain. However, this bill requires physicians to refer patients to physicians who treat pain or a condition causing pain with methods that include the use of opiates. Board staff believes this is problematic because it requires a physician to refer the patient to another physician. If the physician does not know of another physician to refer the patient to, the physician would be in violation of law. Board staff believes that this bill should be amended to be permissive or to provide an exclusion for physicians who do not know of another physician to refer their patients to, or to provide a referral to a website that would include a list of physicians, such as one or more of the American Board of Medical Specialties physician sites. And an example of that website is in your packets. And the other changes in the bill are technical in nature. Board staff is suggesting a support of amended position, with the amendment being for the bill to be permissive or flexible in referrals.
Do you have a motion, please?
So move.
A second? Do I have public comment? Do I have any comment or questions from the board? Dr. Lowe?
Who exactly is going to amend it?
It would be the author's office that would need to amend it. I've actually provided technical assistance, and so it's something that they seem amenable to.
Any other questions, Dr. Lowe?
I can't believe that any doctor doesn't know a pain doctor to refer a patient to.
Can't hear your comment, sir.
I can't believe that there's any physician that doesn't prescribe pain medications like opiates that doesn't know somebody else to refer them to. I mean, there are pain clinics everywhere.
Yeah, and I'm not a physician, so if you think that amendment's not necessary, it's not something that we have to take. We could go with the straight support.
I would think that the Cancer Society that sponsored the bill would have thought this over. I mean, are they aware of it?
I talked to the author's office. I did not talk to the sponsor, so... But they did not seem like this issue had come up before.
Okay.
So what I'm hearing from our board member is that maybe we don't need to push for the amendment. Is that correct, sir?
Well, if the amendment doesn't pass, are we still supporting it or not?
Well, I mean, we can take a straight support and not offer the amendment, or I guess we could take a straight support and just suggest the amendment, but still keep a support position.
Dr. Lowe, do you have a recommendation?
I don't understand all the issues, so no.
Dr. Salmonson?
Well, I'm always in favor of flexibility, and there may have been some reason where this might have been an issue. I like the amendment. I prefer to support with that amendment and not a straight support.
Any other comments from any board members? Any other public support? Public questions, sorry. All those in favor of the support as with an amendment, please say aye.
Aye.
Any opposed? Thank you. Moving on, Ms.
Moving on, AB 536 MA. This bill is sponsored by the Union of American Physicians and Dentists. It would require the board to remove misdemeanor or felony convictions posted by the board on the internet within 90 days of receiving a certified copy of an expungement order from the licensee. The board strives to keep accurate information on the website, and board staff is suggesting a support position on this bill.
Ms. Scurry, could you give us a comment on this, please, first, as part of this presentation? I'll give you the mic.
I do wish to point out that there is a difference between having your conviction expunged after you've been good for a year and being found factually innocent of a charge. In this situation, it would be helpful to the board and the staff who have to answer many questions and deal with folks who make requests on the topic of expungement of their record. If the bill could be amended to clarify that it does not mean that the board must purge its files, especially if the public document, such as a decision, references the expunged conviction, because that may very well be the case. So I would just suggest that it would be helpful to clarify, if the language clarified that this does not mean that the board must purge its files, if it's simply a removal from posting from the internet.
So may I have a motion that includes the comments of our attorney, Ms. Scurry? No motion?
So moved.
Second? Second. Okay, so now we'll have discussion on the motion. We have public, Ms. Felsman?
Good afternoon. Julie D'Angelo, Falmouth from the Center for Public Interest Law.
Speak more clearly into the microphone. I'm having a hard time.
I will. Thank you. This is Julie D'Angelo, Falmouth from the Center for Public Interest Law. We have a problem with this bill, we have not taken a formal position on it, but I want to alert you to our problem, and I urge you to be very careful with this bill and bills like this bill. This board has been disclosing felony convictions on its internet website since 1998. That's 13 years, because of the passage of a bill creating Business and Professions Code Section 2027. That bill requires this board to post certain pieces of information about physicians on its website. This bill was passed a long time before most of you were even on this board. It took all of us a very long time to get that bill passed, and because of that bill and some follow-up legislation, your website is now ranked in the top 10 of the United States by Public Citizen in its ranking of medical board websites.
Number 7.
Excuse me, could you repeat that? I didn't hear.
Yes, I will
Who?
repeat
What?
that.
Number
Your
7.
website.
I just read it this afternoon. I searched for it.
Sorry, I
It's
didn't
here.
hear. I wasn't clear.
Yes, Public Citizen, the infamous consumer group in Washington, D.C., ranks medical board websites. Because of 2027 and because of some bills clarifying your website since then, Public Citizen has ranked the Medical Board of California's website in the top 10 of medical board websites in the United States. 2027 requires you to post many items on your website, items of information about physician performance, physician history. Most of those items are required to come off the website after 10 years, with 2 exceptions, one of which is felony convictions. Those are supposed to be posted indefinitely, and that's been state law since 1998. A felony conviction is a very serious matter. Expungement, as your counsel stated, does not necessarily mean that the doctor did not commit the act that resulted in the felony conviction. If a felony conviction is expunged, I would rather have your website simply say, this felony conviction has been expunged, rather than taking it off the website. This is a slippery slope cutback on your long-standing public disclosure laws, which have served this board well and have served patients well. And I urge you to be very wary of this and very careful of this kind of bill that attempts to undo long-standing public protection laws. Thank you.
Before you leave, let me ask you a question. You weren't as vocal on the idea of taking off misdemeanors. Is that correct? Or would you go along with also misdemeanor expunged?
Misdemeanors have only been posted on your website for the last 2 or 3 years, and they are only posted if they are the basis of an accusation, a pending accusation, or a disciplinary action. I would have the same feeling about misdemeanors, but I am especially concerned about felony convictions.
Thank you. Mr. Hepler?
Again, my comment that reluctantly I speak because things don't get better. Case law suggests that even if you have your conviction expunged, that does not render it a legal nullity, meaning it still happened. The purpose of 1203.4, which is the expungement section, is to sort of promote good behavior while you're on probation. And to that extent, the code section itself says if you apply for licensure after having a conviction expunged, you still must list that on your application for any state license. So there is obviously some concern of the legislature. You still need to tell the appropriate licensing agency that you were convicted, even though it has been expunged.
So any other public comment? I have from the Department of Consumer Affairs, please. And then you'll also remember to get me a slip, okay?
LaVon Powell, representing the Director of the Department of Consumer Affairs. We're opposed to any bill that will make it more difficult for consumers to access public information. I mean, that just goes without saying, and I think this bill does that. And I agree with Kurt, your legal counsel, regarding what does expungement mean. They're very easy to get. And sometimes they still owe us money, and a judge will give them an expungement order. They owe us cost recovery, for example. So be very wary, and I would urge you to not support a bill that did that. Thank you.
Thank you. What is the recommendation? I'm sorry, I don't have the bill.
Support.
We were going to do support with Anita's amendment, but it's up to the board what.
I guess I'll remove my motion. Move to oppose. I'll change my motion.
Okay, so the maker of the motion has changed the motion to move to oppose. There's a second of the motion, except the motion's maker. Second was Dr. Salmonson. Was that you?
No.
Who was second? Dr. Dago?
Right. I will move to oppose it. I second the opposition.
So let me ask you a question, just a technical question. Is it better for this board to be at the table to make sure that this doesn't go forward and then have a motion on the table to support with amendments versus not to be at the table and a vote to oppose? Could I hear some kind of counsel on that, please?
Well, I think if you want to be at the table, it should either be support if amended or oppose unless amended, because that gives them something to work with us on. If we go straight oppose, it's basically saying that we're opposed no matter what. Nothing we can do can make the bill better.
So perhaps it could be an oppose unless amended to modify it to reflect that if a conviction has been expunged, the board will post the notice or the information about the expungement on the website in addition to posting the conviction.
Right, so I'm sorry to interrupt, but leave the conviction on, but also post the expungement order. Right.
Okay, so we have still the motion as it stands, unless you're willing to take the
Why don't we
revised recommendation of counsel.
All right. I'll take the revised one. But
Okay,
this
and
will be
will
the
this-
third motion.
Okay, so with as stated by your counsel,
Yeah.
Ms. Whitney.
Yes.
And the maker of the motion accepts that as well?
Second.
Second, okay, and the second maker makes it okay. Support if amended with the words specifically as stated by, to require posting of the fact of expungement. Okay?
I thought it was.
So what's the exact language?
Wait there, we're having a legal discussion here, which I'm not part of. So with the motion as amended by council, the maker and the second agree. So, and there's any more public comment on that? Yes.
It's OUA. I think we left.
Oh wait,
OUA.
so I'm.
I thought it was oppose unless amended.
Yeah, it was OUA.
Unless amended to modify it. Unless amended to modify it to require the posting of the fact of the expungement rather than removal of the conviction.
Right. So right.
So
Okay.
can you repeat that one more time?
It's opposed unless amended with the admonition of council. Okay. All those.
I'm sorry that
Sorry.
the conviction would stay on, but we would post the fact of expungement. That's
Correct. All those in favor of the motion as it stands now, please say aye.
Aye.
Any opposed? Any abstentions? Thank you very much.
Okay, next bill, AB 589 Perea. This bill is sponsored by the California Medical Association. This bill would create the Stephen M. Thompson Medical School Scholarship Program, hereon referred to as STM-SSP, within the Health Professions Education Foundation. STM-SSP participants must commit to, in writing, to 3 years of full-time professional practice in direct patient care in an eligible setting. The maximum amount per total scholarship is $105,000. The STM-SSP would be funded by funds transferred from the Managed Care Administrative Fines and Penalties Fund that are in excess of the first million, including accrued interest, as the first million in funds, the STLRP, the Stephen M. Thompson Loan Repayment Program. HPA Health Professions Education Foundation may seek and receive matching funds from foundations and private sources to be placed in the STM-SSP account. The author's office believes this bill will help to address the disparity of physician supply in California, as well as the increasing cost of medical education. Board staff is suggesting a support position on this bill.
Okay, any public comment on this? Any comment from any of the board members? Can I have a motion to approve, to support, please?
So moved.
Second?
Second.
All those in favor say aye.
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 Opposed? So carried.
Thank you. The next bill up is AB 783 Hayashi, which is co-sponsored by the California Medical Association, the California Orthopedic Association, and the California Podiatric Medical Association. This bill would add licensed physical therapists and occupational therapists to the list of healing arts practitioners who may be shareholders, officers, directors, or professional employees of a medical corporation. Since 1990, the Physical Therapy Board has allowed physical therapists to be employed by medical corporations. In September of 2010, the California Legislative Council issued a legal opinion that concluded a physical therapist may not be employed by a professional medical corporation, and stated that only professional physical therapy corporations or naturopathic corporations may employ physical therapists. This issue came to the legislature attention when existing law was amended to add naturopathic doctor corporations and physical therapists were specifically listed. Because the medical corporation section of the law did not specifically list physical therapists, the issue was brought to the forefront and to the California Legislative Council. Currently, many physical therapists are employed by medical corporations or physicians. According to the author's office, this bill was introduced to prevent the unnecessary loss of employment during this economic recession by allowing medical and podiatric medical corporations to continue to employ physical therapists as they have done for over 21 years. This bill will codify the practice that has been allowed, existing practice, and allow physicians and medical corporations to employ physical therapists. Board staff is suggesting a support position on this bill.
Okay, do I have a motion on the table to support?
Move to support.
Any to support? Any a second?
Second.
Do I have public comment? Do I have any comment or questions from the medical from the board? All those in favor, please say aye.
Aye.
Any opposed? Thank you.
Okay, next I'm going to quickly talk about, there's 3 direct employment bills in the legislature this year. They're similar to the direct employments from bills that were in the last couple years. However, all these bills have recently turned into 2-year bills, with the exception of one bill, the Hayashi bill, which because it has an urgency clause, it doesn't have the same deadlines. However, the language placed in the Hayashi bill is it's basically a placeholder, so it will change if it moves. I'm proposing to not go over these bills with you because they are 2-year bills.
Appreciate that. Anyone object to that? Thank you. No.
Okay, so we're going to pass through 824. Okay. The next bill up is AB 895 Halderman. This bill would provide a tax credit of up to $5,000 for physicians and surgeons and osteopathic physicians and surgeons who provide qualified medical services. Qualified medical services are defined as services provided free of charge or at a reduced rate at a local community clinic or in an emergency department. Because of the bill's position that we've taken in the past on promoting volunteer services, and because this bill would provide an incentive for physicians who volunteer their services at community clinics and emergency departments, board staff was suggesting a support position.
Can I have a motion, please? To support? Motion, please?
Sure.
Second? Any public comment on this? Okay.
Okay, so the next bill is 926.
Wait, no, we've got public comment. Sorry.
Karen Ehrlich, Midwifery Advisory Council. I would simply like to ask the board to consider adding allied health professionals into those who can get this tax credit for free services.
Can I ask just a clarification? I assume this would not include bad debt, but it is just services that are provided prospectively with no intention of being reimbursed for them. Is that correct?
Correct.
And I'm assuming the Appropriations Committee will have some say on this, given that there's a fair amount of revenue to be lost.
Exactly.
Got it. Okay.
Okay, so let's remember that this is not going too, I don't know where bill is going to go, but is that a nice way of saying it's not going? Anyway, so what I would recommend is that if people think that, and Karen, if you think that this should have additional amendments to it or another group, that the author's office needs to be contacted by you, okay? So, all those in favor of any other public comment? No. Any, okay. All those in favor of the motion as it is to support, say aye. Aye. Opposed? Next, please.
Next bill is 926 Hayashi, which we're skipping. The next bill up is AB 958 Berry Hill, which is actually a 2-year bill too, so we're proposing that we skip that since it's a 2-year bill.
Done.
Okay. The next bill, AB 1360, is one of the direct employment bills. That's a 2-year bill, so I propose to skip that one.
Seems like the Assembly is busier than the Senate.
Okay, which takes us to our first bill up, SB 100 Price in the Senate. This was actually brought to the board at the last meeting in January, and we took a supportive amended position. However, this bill has been significantly amended to take out all provisions regarding licensing of outpatient settings by the California Department of Public Health. It was also amended to take out all provisions related to advertising. There's some new requirements for outpatient settings and accreditation agencies. Some of the biggest ones, it would allow the board to adopt regulations to specify procedures that should be performed in an accredited setting, to address concerns that some procedures do not currently have to be accredited. It will require the board, the listing of information that the board is required to have on outpatient settings to be posted on the board's internet website, and it also requires the accreditation agencies to provide that information to the board, which is one of our previous concerns. Let's see. It also sets up a process for plan of correction and deficiencies for outpatient settings and accrediting agencies, and for the for our board to get that information. Let's see. Okay, and it also just moving faster through this. Okay, and also require the board to investigate all complaints concerning a violation of the chapter that on unaccredited facilities. Currently, if we receive this type of complaint, it would be forwarded to the district attorney. The bill would require the board to investigate all these types of the complaints, which would add to our workload. Right now, we would be giving this workload to the Operation Safe Medicine unit, but that might not be an option if it's not extended in the budget. So board staff is suggesting a supportive amended position. We believe technical amendments are needed to make one of the things the bill does is make the final inspection reports available at the board and available to the public. Board staff believes that only the final report shall be available to the public, and that's it. So we're suggesting a supportive amended position.
May I have a motion to that effect, please? This is the motion that's most important right now, currently, and if we want to be at the table to have some impact and effect on surgery centers, here's where your opportunity is.
So move.
Okay, thank you. Second. I need a second. Second, okay. Mr. Heffler?
Again, here we go. Just want to point out, I think under technical amendments, one of the things the board should consider is that Ms. Mose touched on it about we shall bring an injunction if we determine that an outpatient setting is not in compliance. I believe that should be permissive and not mandatory. If we can get compliance some other way, then I don't believe we need to file an injunction to do such a thing. The second thing is, one of the things, if somebody wants to find out a complaint, if somebody makes a public record request for a complaint or an investigation, we do not give that out under Section 6254F of the Government Code, because that's a complaint file made to a state licensing agency, presumably because the agency is investigating its own licensees. Here, that's not the case. These outpatient surgery centers would not necessarily be our licensees. I would ask that the board consider extending that coverage from non-exemption of disclosure to the investigations that we do pursuant to the section of an outpatient surgery centering. Specifically inspection reports or investigation reports. The third thing is, I think, just want to point out, as we talked about yesterday in the Physician Advisory Committee, it's my understanding this amends Section 2023.5 of the Business Professions Code to require the board to adopt regulations regarding physician availability for the use of laser or IPL devices. It's my understanding that currently the board did hold its forums, did not determine that no regulations were necessary, alternatively that the existing laws needed to be enforced. Am I correct with that?
Yes, I believe so. That part was in the last version. That's why I didn't go over it.
Okay.
Dr. Solmonson.
Well, I'm a little unclear on how I will want to vote on this because I'm not sure about those changes. And now, what's the difference between supportive amendment or support in concept? Somehow support in concept seems a little softer and might be more where I stand because I'm not quite sure where it is right now.
Well, I think the supportive amended position gets us really to the table to kind of like Barbara was, or Ms. Yaroslavsky was saying, is to work with the author's office and various stakeholders. This bill is going to change again. I have a call in to meet next week to go over more potential changes. So I think a supportive amended position will give us really the ability to go and really go forth with the changes that legal is suggesting and any other changes that may come up with subsequent versions of this bill.
I'm just wondering if we're sort of signing on to be the inspector of surgery centers.
Not necessarily. I think what we're signing on is to be at a good place at the table, given the author of this.
That's good. Okay.
And I think that it's incumbent upon all of us to read this legislation, this one specifically, very, very carefully, and be sure to get back to Ms. Somoza, our Executive Director, with your comments and your input, because here we have a chance to make a difference for real.
Okay.
Finally.
Good. Good.
So, all those, any public comment on this? No. Any other comment from members? Thank you. All those in favor of the amendment as stated? Support if amended, please say aye.
Aye.
Any opposed? Thank you. Ms. Simos?
Okay, next bill, SB 233 Pavley is sponsored by the California Academy of Physician Assistants. This bill would explicitly clarify that a physician assistant PA can provide treatment and consultation in an emergency care setting. It's basically clarifying existing law. There was an instance that came up where a PA was not allowed to provide the services they would normally provide because it was an emergency department. Board staff is suggesting a support position on this bill.
May I have a motion, please?
So moved.
Any public comment? Any comment from any of the members or questions? All those in favor, please say aye.
Aye.
Any opposed? Thank you. Continue.
Okay, next bill, SB 380 Right. I mean, that's one of the updated bills that you were given today. This bill originally dealt with mandated CME. It has recently been changed. And it was related to address opposition's concerns. This bill would now authorize the board to set content standards for any educational activity concerning a chronic disease that includes appropriate information on the impact, prevention, and cure of the chronic disease by the application of changes in nutrition and lifestyle behavior. Before, it was a mandated CME bill on nutrition and lifestyle changes related to chronic disease. But it is important to note that the bill only allows the board to set content standards. It does not require the bill to set content standards, so it's something that at a future time, if the board decided that this is something that we should do, it gives us the authority to do that. Board staff is suggesting a neutral position just because this is an issue that's affecting many Californians. There's chronic disease is rampant. I did talk to one of our medical consultants, and he did agree that there's not a lot of education given to medical graduates on nutrition and lifestyle behavior changes, and so board staff is suggesting a neutral position.
First of all, let me have a motion. A motion? A motion?
I'll make the
It
motion.
might die for lack of a motion in about 10 seconds.
I'll make the motion.
Okay, second? It's going to die for lack of a second. It dies for lack of a second.
So, no position.
I
right.
would like to remind you all that we've been through the mandating of CME for the disease of the month before.
Well, there's another one coming up. So, okay, the next bill is SB 544 Price. We are going to skip this one because it's a 2-year, if that's okay with the board. But it's the new CPI bill. We'll be talking about it at a future time, I'm sure.
Future.
Okay, the next bill, speaking of mandated CME. All right. Sorry, I have to forward my notes here. Okay. SB 747 Kehoe is sponsored by Equality California, and it would require physicians and surgeons, registered nurses, LVNs, psychologists, PAs, psychiatric technicians, marriage and family therapists, and clinical social workers to complete a one-time continuing education course that provides instruction on cultural competency, sensitivity, and best practices for providing adequate care to lesbian, gay, bisexual, and transgender persons. This is a one-time requirement modeled after current requirements in law. According to the sponsor, LGBT community has specific medical needs and concerns, and it's critical that healthcare professionals receive necessary training to understand those needs. As stated before, although the board usually opposes mandated CME because of the board's interest in preventing and addressing health disparities and promoting cultural competency, because of the fact that every physician and surgeon in California may have the opportunity to provide services and treat LGBT patients, and because it's only a one-time requirement, board staff is suggesting a neutral position.
Do I have a motion? It's going to die for lack of a motion.
So noted.
I think it's an important issue without question, and I would hope that the educational entities in the state would try and get on board with educating their people, period. It's very important, but I think we have to be fair and equal.
Okay. Okay, so last but not least, SB 824 Negrete McLeod is co-sponsored by Lens Crafters, Target Optical, and Sears Optical. It would require a RDO, a registered dispensing optician, acquiring ownership of a business to file notice with the board within 10 days of the completion of the transfer of ownership. It would make the RDO selling or transferring the ownership interest responsible for complying with all laws relating to the place of business until cancellation notice is received by the board. According to the sponsors, this was brought by a situation where there was a change of ownership, and because of the requirements in existing law, they couldn't both get their paperwork in time. So currently the board does have some issues receiving both the new RDO application and the notice of cancellation. We have to match those two documents up. Putting a 10-day timeline on both parties to get their required paperwork into the board would make this process run more smoothly and effectively, and also makes it clear who's the responsible party. So board staff is suggesting a support position on this bill.
We have a motion? Second? Any public comment? Any questions from the board? All those in favor, please say aye. Aye. Any opposed? So
lastly, in your board packet is just your Tracker 2 list. You can look over those on your own time, unless anyone has questions on the Tracker 2 list.
No, they don't have any questions. I'll look at them on their own time. Thank you very much.
Yes. So the next agenda item is the matrix status of pending regulations. There's only one update on the second one on the chart, abandonment of application files. That was recently sent to the Secretary of State on April 26th. That's my only update, unless anyone has questions.
That's great. Okay, anyone have questions? That's wonderful. Okay, none. Okay, so that's it. Thank you very much, Ms. Simoes. You're really very, very good. So we're going to move. 22, we did have a presentation that we were going to hear from CMA, and I want to thank them for deferring to the time and the clock, and they'll present in July. Moving on to 24, Mr. Warden, licensing. What about this? Oh, if you think I remember, yeah, the one who you couldn't hear. Now, Mr. Warden, feel free to give us the good news, the bad news, and quickly.
Okay, I'll keep my report brief for you, as most of it's been discussed in the licensing committee. The main thing I want to say is that the staff has done an excellent job to be in the position they are for licensing, and that as of this week, our initial review dates for U.S. files was 36 days and 30 for IM international graduates, and the 7 days for pending amount. The next scheduled special faculty permit is June 16th. We do not have any applications at this time. If we do not receive any by May 9th, we will be canceling that meeting. The international medical schools have interest in applying, have been getting several inquiries on that, and have received 2 recent applications or starts of applications. We have 1 pending specialty board application and 1 inquiry on another one. And our PolySom program is in the final stage of drafting the final statement of reasons, and in support of the AB 2386, that form has been approved and is now posted on the website, and that is actually on page 231 of your packet. And that concludes my report.
Thank you very much, Mr. Warden. Please, thank you very much. I'm going to ask if there are any questions or no questions. Thank you very much. Let's move on to the Midwifery Advisory Council update. Karen, now you're going to get the same admonition. Give us, I know you've been waiting patiently all day for 2 days, but please.
We are moving forward with the midwifery reporting, the statistical reporting. OSHPED has worked hard, and the board's information systems branch has worked hard to help prevent reporting errors for electronic filers, and we are grateful for their efforts. That certainly has lessened reporting errors. The Midwifery Advisory Council is exploring the option of working with the Midwives Alliance of North America Statistics Project to allow for prospective reporting of data. We believe that this would be superior to the data that we can get with the retrospective collection that we have now. I'll skip the rest of that. Update on physician supervision. At the April 7th, 2011 meeting, Dr. Ruth Haskins, one of the 2 OBGYN members on the council, presented a collaborative practice statement issued by ACOG and the ACNM. The statement is included in the board packet on page 249. The joint statement is part of an ongoing initiative to promote collaborative practice between obstetrician gynecologists and certified nurse midwives and/or certified midwives. We are gratified and pleased at this effort on the part of ACOG and the ACNM to move toward collaboration. Licensed midwives look forward to further discussion so that together we can craft a framework for collaborative practice that benefits California's OB/GYNs and licensed midwives and the families that we serve. Section 2507 of the Business and Professions Code requires that the board adopt regulations defining the level of supervision required for the practice of midwifery. All previous attempts to do so, however, have resulted in an impasse due to widely differing views among medical, midwifery, and insurance professions on what are the appropriate levels for supervision. With the issuance of the collaborative practice statement and the board's previous authorization allowing the council to address this issue, we will rekindle previous efforts to define physician supervision and perhaps introduce the concept of collaborative practice via regulation. The recommendation to pursue regulations to ensure that midwifery practice and educational requirements are consistent. Current regulations and law spell out the educational requirements, it is a current regulations, spell out the educational requirements for midwifery education. Title 16 CCR 1379.30. The education program must prepare the midwife for the management of normal pregnancy, labor, and delivery, including the administration of IV fluids, postpartum oxytocin, RhoGAM, local anesthesia, vitamin K, eye prophylaxis, among others. However, current regulations do not specifically authorize the licensed midwife to incorporate these requirements into her practice. As such, midwives often face difficulty in securing necessary supplies, such as oxygen, anesthetics, oxytocin, among others, in order to practice safely and effectively. In an effort to address this barrier to care as previously authorized by the board, the council would like to propose that staff move forward to develop regulations to ensure that midwifery practice and educational requirements are consistent. So the regulation that we would like to see is one that actually states that we have the authority to use those things that we are educated for. Report for the board authorization to consider modifying the size and or composition of the Midwifery Advisory Council. The current council, as decided by the medical board at its inception, is 6 members. By law, half of them must be licensed midwives. There are 2 obstetricians on our board, and Ms. Yaroslavsky as the board's representative and a public member. It has always been a value of midwives in our community, in the midwife community, that we have representation by citizens who have the experience of being cared for by midwives. And we would like the board to consider the addition of what will have to be 2 slots on the board, on the council. One for a parent who has been served by a licensed midwife, and then the other, in order to keep within the mandate of the formation of the Midwifery Advisory Council, that the other would have to be another licensed midwife. Personally, I also would like to see that new licensed midwife would be someone from Southern California. Currently, all of the licensed midwives are Northern Californians, and I think it would be beneficial to all of us to have a Southern California voice. Thank you. I'm done.
So I think we need to entertain a motion to have the staff work on regulations related to educational requirements, correct?
Yes.
So I need a motion to that effect.
So moved.
Second?
Second.
Any public comment? Any comment from the members here? All those in favor, please say aye.
Aye.
Any opposed? Any abstentions? Thank you. So that's done. Now, as far as the increase in the number and the composition, did the council vote to do that, in fact? To bring it?
If I could, I believe the motion, having attended that meeting, and Ms. Thompson, you can back me up, I believe the motion was, in fact, for the MAC to request authorization from the board to study the issue of perhaps expanding the allocation of members to the MAC and the composition thereof.
Okay, so be it that that is correct.
What
does that mean? That means we're going to study?
I think that
we're going to refer that issue back to Midwifery Advisory.
So, in other words, we are going to be given
so
the authority
correct,
to explore this and ask for
I
a motion
apologize,
from
yes.
the board.
Okay, thank you.
Thank you.
Thank you for your report. It was very timely, quick, and concise.
Did we vote on that? I'm sorry.
All those in favor of that recommendation to send it back to the MAC? Oh, I need a motion.
So moved.
Second?
Second.
All those in favor of moving that back to the MAC, please say aye. Aye. Any opposed? Thank you. I apologize. I'm starting to get punchy. I don't know about punchy. We're up to number 26. Renee, you're up. Now, same admonition, I know. I know.
I think I'd like a special dispensation.
Okay, then do I have time to?
Okay. Moving to agenda item 26A, I'd like a motion to approve 9 orders restoring licenses to full status following completion of probation, and 4 orders for surrender of license during probation or administrative action.
Do I have a motion?
So moved.
Second?
Second.
Is there any discussion on the motion? Is there any public comment on the motion? All those in favor, please say aye.
Aye.
Any opposed? Thank you very much. That's done.
Moving to agenda item 26B on page 251. I'd just like to note that there are 1,262 active experts in our database, and during this last quarter, we utilized 140 experts during the quarter to review 180 cases.
So you had enough experts to do the reviews you needed?
Yes.
Thank you.
Moving to my report, the district office vacancy rate for investigators is currently hovering around 9%. However, the vacancy rate for supervising investigators has reached 29%. We are seeking freeze exemptions for these vacancies, and I received word that the supervising investigator freeze waiver is ready to be submitted to DCA. Ready to be the waiver. Oh, excuse me. No, it needed, no, it's ready to be finalized. It needed some more work.
So when is that going to be going forward?
I think
Monday morning?
I think they'll be finalizing it this week. We had a retired annuitant is working on answering their questions and has prepared the data in response to additional information that they sought.
Thank you.
And so that has gone, or will be going over to DCA this week. It should have gone today.
So Monday will it go?
No, when I
it's
get
there.
back to the
Okay,
office,
I
it should be,
apologize.
as I speak, it should be.
Okay, I apologize. I thought it was still in process.
Since the notice of consumers posting became effective, the volume of complaints received by the board has increased an average of 60 complaints per month. The Central Complaint Unit is experiencing an unprecedented number of vacancies as a result of retirements and promotions, with professional staff vacancies anticipated to reach about 30% over the next 2 months. It is clear that we must re-examine where our resources are being expended by staff in the complaint unit and adjust accordingly. Recruitment efforts to fill the vacant positions has been somewhat impacted by the recent hiring freeze, as the recruitment pool is limited to existing DCA employees. We're continuing to seek hiring freeze exemptions. However, while we are faced with diminishing resources, we will not be able to pursue a number of complaint types, such as certain advertising violations, FNP issues, fee splitting, coupons containing offers for medical services, HIPAA violations, breach of confidentiality, and testimony by medical experts. Complaints involving those.
Any questions from the board? Any public comment? Seeing none. Anything you're seeking?
No, we've made the decision that we have to do this. So.
Okay.
Yeah.
The aforementioned complaints, I will add, can be closed with a disposition code reflecting lack of resources, and we can receive them when things turn around for us in order to work them, so they aren't going to be lost. So we just can't work them right now. Moving to, I'm going to. One of the reasons we're having a resource problem, it has to do with promotions, and I just wanted to publicly acknowledge the work that has been done in our citation and fine program by Anthony Salgado, who has been promoted to a manager position in licensing, and I'd like to congratulate Anthony and wish him well. Mm-hmm. It's a tremendous loss to enforcement.
It's an example of stealing within our own, but also promoting, which is very, very good for the morale of staff.
Sure.
I presented some of the data regarding the data markers that we have in place during the enforcement committee. And although the data was too limited to make program changes, we are going to be looking more closely at the markers to determine if there are policy changes that we need to make in order to process the cases more quickly. One thing I would like to point out, however, is despite the furloughs, staffing shortages, and inability to replace vacant staff investigators, investigators reduced the time it takes to resolve a case by 28 days between fiscal years 08, 09, and 10, 11. So that is one notable thing, that even though I could just imagine how much more we could do with adequate resources and removal of limitations on furloughs, limitations like furloughs and other restrictions. So that is my report, and if you have any questions, I will try to answer them.
Does anyone have any questions for Ms. Threadgill? Thank you very much for your report.
Okay.
Moving vertical enforcement. You're still on the, sorry. Continue.
The vertical enforcement statistics are agenda item, can be found on page 255. There's a slight change in the presentation of this data. We finally reached the point where all of the cases in the VE model, all of the cases are in the VE model, and we're reporting them in the all category, meaning that all the cases reflected are in the VE system. So we will no longer have the two separate columns. However, we will keep the columns there for previous years so that just for comparison. In April, we were fortunate enough to have a statewide investigator training and inspector training. I'd like to thank President Barbara Yaroslavsky and Executive Director Linda Whitney for helping to get this to a great send-off, and appreciate their being available for welcoming the investigators, as well as I'd like to thank Dr. Moran for the specialty presentation that she gave. The investigators thank her, and they felt that her presentation was extremely important to the work they do. The training also included a presentation regarding defense attorney techniques, as well as an asset forfeiture presentation, and much, much more. It was really a lot of solid information. But the important part of the investigator training included the deputies from Health Quality Enforcement section. And this was a presentation on medical records acquisition. The training was jointly prepared and jointly presented, and it was extremely invaluable. The experience was quite positive, and as I understand, this is the first time that NBC investigative staff and HQE staff have jointly participated in a statewide training project. And in fact, I think this is the first time that many of the deputies have seen their colleagues from other parts of the state. Anyway, it was a huge success, and I'll let Carlos fill you in further.
Good afternoon, Carlos Ramirez, Office of the Attorney General. You have before you in your packet the statistics for calendar year 2010 at page 256. Following the compilation of those statistics in around March, I believe, early March, we conducted an inventory of all cases, all medical board cases that were within HQE, in which accusations had not been filed and in which notices of defense had not been sent, or requests for hearings have not been sent. Following that compilation, I issued a directive that all cases, all medical board cases, should be filed by March 25th, close of business, and that all requests to set, not previously sent, be sent by that date also. By the end of March, all the cases that had not been filed, that were unfiled cases, were in fact filed, with the exception of 2. We then continued to monitor the progress of cases, and as of April 21st, we had 11 cases that had not been filed. Since that time, 8 of those cases have been filed, and 3 have not been unfiled. 3 remain unfiled. We expect to continue monitoring cases not only for the filing of accusations, but also for the request to set hearings on a monthly basis, and we'll be reporting to you at the next board meeting.
I want to take a moment of personal privilege to thank Carlos for the statistics. It's the first time we've had them in our packet, and I think it should be helpful that hopefully people have reviewed them and seen them in advance of hearing the report. So thank you for all the extra energy and effort working with, doing more with less.
Thank you.
Threadgill, thank you as well. Any questions for our presenters? Mr. Zeruni and I knew.
And I'll be brief. I'll leave the longer questions, if you will, for next time as we're developing that matrix, and I want to give everyone the opportunity to finish that matrix so that, as we talked in the enforcement, to be able to address the issues about the days. But I want to understand a difference here, Carlos. In your report, as I understand it, these are cases opened in calendar year 2010, as opposed to all of the cases, because there is a number difference between Renee's report and your report in, for example, calendar day age from accusation filed to some sort of a disciplinary outcome. Your days obviously are much shorter than what is being reported in the Renee's report. But my understanding is, correct me if I'm wrong, yours is only limited to the cases in 2010 that were started in 2010, as opposed to all of the cases, right?
I believe that's correct.
Okay, because there is a 100-day differential in the average.
I believe, and I may stand corrected, but at the last count, we had maybe 1 or 2 cases in 2009 that were still active, that were still in HQE, but that was because we had there were supplemental cases that we needed to add to the accusation.
Okay. And is it fair to say that I'm comparing apples to apples? If I were to read, if you have in front of you, you can take a look, maybe Renee can show you. I am looking at agenda item 27, page 255, and I'm looking at 2010 VE, the last line item, calendar day, age from accusation filed to the disciplinary outcome. Renee's report shows 340 days. You see that?
To disciplinary outcome?
Yes.
That includes the time at OAH, and I believe Carlos is capturing just the time to file?
No, I think it includes it. So that's what I'm asking. Is it apples to apples, or is it different?
We'll have to see, because there is a significant difference. We were looking at cases that have been completed through 2010. Okay.
Microphone, please.
Microphone.
Yeah. We could, of course, track back the record number by tie it into the respondent number and get back to you as to this count. That's the only way to actually make sure that we're talking about the same universal cases, by identifying them by the respondent number, the respondent name.
Okay, and that's why I asked you earlier whether or not this was only for cases that were opened in the calendar year 2010.
That's right.
Okay, because if that's the case, and Renee's report shows all of the cases, I can understand there is a differential still, because you're not catching up yet to that. But I certainly like your number than the number that we have, and I hope that we'll get to that average of 204 one of these days, but as opposed to 340 still.
If you'd like, I can manufacture some numbers too.
I have numbers too. What kind of numbers do you want?
Well,
we have confidence in our numbers, because what we did, we started with pro-law stats, and then we actually drilled down to the actual case files. So these are just numbers that are not only generated by computer, but are actually have been the subject of hand count by either someone from either the SDAX or someone from my office.
Well, I'll tell you what, since there is a little bit of a distinction and qualifications between the two of you here, while I like the fact that you're doing this in your shop, if you will, I hope that by next time, perhaps, both of you are on the same page as to how these numbers are accounted for, because there is a difference, and that's what I want to make sure that the public sees apples to apples, and that we don't start producing two separate reports with two different numbers diametrically opposed at times, and thereby misleading the board and or the public. I don't want to be in that position. So while I like the number, but again, I want that to be real, and I want that to be compared to the numbers that enforcement has, apples to apples. Yeah. Yep.
Thank you. Any other comments? Comment? Any public comment? Thank you very much for your reports. Oh.
If you could all turn to page 257. SB 1441 required the creation of the uniform standards regarding substance abusing healing arts licensees. These were adopted in early 2010 with one outstanding issue related to standard number 4, the standards governing aspects of biological fluid testing. The committee recently re-reviewed these standards in early April, and they discussed the frequency of testing. So if you'll turn to page 259, I'll point out what the standards were changed to. If you look under the testing frequency schedule, there had been a standard of 104 required tests per year, and now it's developed into 2 different levels, year 1, year 2, with the minimum range of tests, and then there's a caveat that the minimum range of 36 to 104 tests identified in level 2 is for the second year of probation or diversion, and each year thereafter up to 5 years. Thereafter, administration of 1 test per month if there have been no positive tests in the previous 5 consecutive years of probation or diversion. And that was requested by the medical board. That was adopted by the committee, and I just wanted to bring it to your attention. So the uniform standards are complete.
Thank you. Are there any questions from the public? Anyone from the board? Thank you for that report. I'd like to now move on the agenda. Sorry, did I miss?
Sorry, my bad. My bad.
I'd like to move to number 29, Department of Consumer Affairs. Ms. Powell, would you please welcome and thank you for being here. It's your first meeting.
First meeting in this role.
Thank
you. I would like to say that I think your meeting went really well, considering that the amount of staff that you brought was approximately 50% of what you thought you were going to be able to bring, and it was a very short amount of time. And I thought your staff did a very good job of presenting. And I also think because they did so much preparation work and your meeting packet was so well put together that it wasn't as much of a handicap as a board that maybe isn't as well prepared as this board.
Thank you for that. I just want to remind you that it's not only the staff that does it while they're doing the meeting, it's what's going to happen on Monday morning.
Yeah,
so
you're
just
right.
to put in perspective, and the minutes and everything else. So I thank you for your compliment, but I want to put in perspective.
Sure, I understand. And just, you're no shrinking violet, and neither is your executive director, and she fights for you. Trust me, she fights for you. She advocates for you, in a tactful, polite manner. But rest assured that she doesn't give up. She keeps going. So she does a good job for you on that. There will be a budget letter to follow the travel, and it'll have more details. Our department is particularly challenged by this executive order. I mean, for obvious reasons. You know that. You have all of those. I would like to, there's a Breeze update in your board packet. It's very detailed. I don't see any, it's at the very end. I don't see any reason to bore you with that. It's not a bore, but we are in negotiations. It's going well. I can't give you specific details. There's a confidentiality aspect to that. And very quickly, I thought your practice monitor enhancements were great. And I'm looking forward to hearing about the results from that and passing that along to other boards that have practice monitor provisions or are considering them. So any questions you want to answer? I am going to be here, so if you want to, after your meeting adjourns, if you want to come up and ask me any questions, I'd be happy to speak with any board members.
So what I would like to do, first of all, is thank you very much for that opportunity, but I would like to remind you that clarification, the ability to have some discretion, some flexibility, some accountability, some transparency, are all words that mean something a lot to this board. And as you go forward with the constraints and with the challenges, that there needs to be the opportunity to consider the words that I just listed for you, and that I hope you hear us loud and clear, because it looks good, but it's not feeling good. Okay.
Okay.
So I just want to. Does anyone have any questions that they'd like to ask Ms. Powell, who is the representative of the Department of Consumer Affairs? I'd like to remind everyone who she is. I apologize. Thank you very much. So we're going to move on to item number 30, which is the meeting in Sacramento. Do we have some requests for anything to be placed on the agenda?
Well, I just thought maybe we should still do the CMA presentation on workforce.
Absolutely. Thank you. Dr. Carrion? I know.
Yeah, I have two issues that I think we should try to take care. One is that the maternal mortality in California is the highest in the country. That is one. And two is that the abuse and overdosage of prescription drugs is a widespread problem, not only in California, it's around the country. And I think that we as leaders in the public protection, we should try to see how we are going to work with other agencies to try to take care of these two very important problems that we have right now.
So would you like to see maybe an update from the programs that exist as far as prescription drugs in pharmacies? And there are programs in place. I mean, is what you're asking is for some kind of
There is programs in place, but maybe I am not very well educated in this, and I really would like to know more. I did a lot of research in the last few weeks.
Right.
But I want us, as a body, try to help the community not to go to this serious problem.
So maybe some kind of a presentation on what kinds of reporting and what kind of oversight and what kind of education committee kind of opportunity that we could bring that forward. That's a good idea. I'll try and massage that through, but I think that by bringing it forward as maybe part of the education committee or wherever we're going to place it, it puts it out there on the front burner. I'd like to also remind people that Wednesday afternoon prior to the board meeting scheduled will be a strategic planning meeting, and I would hope that everyone be participatory in that. Do I have any other items for the agenda in July in Sacramento? In the coolest part in the country is Sacramento and an air-conditioned room.
It'll work out.
Yes.
Yeah, your hair's short, it'll work out.
It's all good.
Madam Chair.
Okay, I want to ask for a motion to adjourn, please.
Madam Chair.
So
I wonder if it'd be appropriate in July if we could get a presentation from Tony Sullivan on, she actually is the author of Collaborative Care and Collaborative Practice, so that we can start that discussion.
Absolutely. Thank you for that reminder. I would like to see a whole year program where we bring in experts, we bring in opportunities, we bring in on collaborative care programs, and this would be great. And we'll get another one depending on how long you think that presentation should be going for.
And I know budgets are tight, but if there's any way that the board members, particular in access to care, can get access to the book, it would be very helpful.
I would think that's not a problem. If you give the ISB number to our executive director and order a dozen copies, I'm sure that DCA would be happy to make sure that we know what's going on in the world.
Linda, I think I had sent that to you prior to the meeting. Yeah, thanks.
Dave, it's done. Okay, thank you all very much for attending. Thank you for staff. Excuse me, Ms. Thompson? The flash drives need to be turned in to Ms. Thompson, please. And that's it. Turn off the camera.